Dr. Kelvin? Dr. Sean? Aniruddha?
Yes, I can hear you.
Yeah, can we get your
Can you
picture?
hear me all right?
Yeah.
Yeah.
Hi, Kelvin. Yes, we can hear you.
Perfect. I was able to get the background too.
All right.
We're taking a screenshot. If you can show your picture, your photograph or your face.
Yeah, your face is not visible, Dr. Sean.
Oh, it's not. Okay. Is it better?
No.
No, it's not there.
Seen at all.
He's there on 2 accounts. He's there on 2 accounts. Dr. Sean is probably on the second page.
Okay, 1 second.
So we are live.
Do you see me now?
No, it's not visible.
1 second.
I see you, sir.
Good evening, good evening, good evening. Good evening to our judges, our international judges. Good evening to our chairpersons, and good evening to our participants of today. And most importantly, to every one of you who has logged in for this grand finale of the talent search program of AIOS Scientific Committee. Thank you very much for being here with us this evening, and it's going to be an exciting, a vibrant, and a very, very important evening, because the talent from India is going to show up in the different presentations of 4 minutes. And we have international judges who are going to ask them questions, understand what the presentation is, and give marks. All of our participants are winners, and all of them have abundant talent. But this evening, we have to choose the top 5. And the first place, whoever gets onto that, is going to get a cash award of rupees 50,000. The second place, the awardee, is going to get 30,000. The third place, 20,000. And in the fourth and the fifth places, they are going to receive rupees 10,000 each. But it's not the check, but it's the participation, it's the show of talent, and it's to take this talent forward nationally and internationally that we have today's AIOS Scientific Committee Grand Finale Talent Search. And I would like to introduce to you our Governing Council members from the AIOS, and we have with us our President, Dr. Mahipal Singh Sachdev. Thank you, sir, for joining us. Dr. Barung Nayak, President-elect. Dr. Lalit Verma, Vice President, AIOS. Dr. S. Natarajan, immediate past President. Dr. Namrata Sharma, our General Secretary. Dr. Rajesh Sinha, our Treasurer. Dr. Santosh Rawar, our Editor Journal. Dr. Arup Chakravarti, Editor Proceedings. Dr. Chitra Ramamurthy, Chairperson ARC. And we have our phenomenal Team Scientific Committee of Dr. Amit Porwal, Dr. Fairouz, Dr. Jatinder Singh Bhalla, Dr. Krishna Prasad Kudlu, Dr. Parikshit Gopte, Dr. Somshila Murthy, and Dr. Sonu Goel. And believe me, the hard work has been done by the Team Scientific Committee, and all of us welcome you to this grand finale of the talent search. I have the great pleasure of requesting Dr. Mahipal sir to say a few words in welcome.
Thank you very much, Partha. And in the first instance, I'll wish to welcome all the, I would say, the galaxy of international judges that you have been able to get for this particular grand finale of the talent search competition. This started a couple of months ago, and it has been a tough and a grueling sessions wherein first the state societies nominated certain people after a search, and then it went on to a particular zone, and from the zones various people came out winners, and now we have the grand finale. Now, what has been the hallmark of all of these youngsters has been the enormous amount of thought process, the new ideas, the innovations, and the talent behind their thought process. I think all of them are really the future of ophthalmology of India. And mind you, it is talent that one has to nurture. And I think Partha, you as the chairman of the scientific committee and all the members of the scientific committee, along with the able guidance of the governing council, is trying to do just that very thing. I think what India rightfully deserves today is its place in the global ophthalmology, which has been growing over time. And that has been because of the new innovations that we have been doing by the people, whether it was in techniques, whether it was in technology, etc. The only thing is that still we don't have so much of money pouring into research, and that is something that has to come. But I think these brilliant ideas which these youngsters are going to give has been despite and in spite of not having great funding. And I'm sure the judges will find it very difficult to judge as to who out of them is giving better idea that is going to improve ophthalmology for all times to come. Friends, I would just wish to say that all of you who have reached this stage are really great, and they are winners. And it is the idea that you are throwing that is most important, that you have to participate and you have to hone your skills and your ideas and your innovations to bring out the best. So without saying anything much, except for the fact that at least all of us who are into the next generation are really, really very, very proud of the youngsters as to the great work and the thought process and the mindsets that they have. And I wish them always all the very best. And we will be wanting to help them in whatever way it is possible to bring their innovations into commercialization and fruition. So without wasting any more time, I would wish to say that let us look forward to a great engrossing session. It will be a learning session for all of us, and I think each speaker is going to do better than the others. So thank you very much, Partha, for organizing this once again, and let's look forward to the scintillating grand finale of the talent search of All India Ophthalmological Society.
Thank you very much, sir. Dr. Lalit Verma, sir, just a few words from you.
Yeah. Namaste to everybody. You see, today is a grand day. Why? So, in the history of scientific committee, and today is a grand day for the history of AIOS also, because we have 8 international judges. And thanks, Partho, for the hard work. You see, as Mahipal said, talent abounds in India. And this has been seen by us all for last, 5 weeks we have been seeing. And thanks to the, great job done by Partha and his team of scientific committee. And we have seen these 5 rounds being conducted by the scientific committee of AIOS. And for me, all 16 are winners here. Although ultimately, few will ultimately reach the podium, but all these 16 young tucks, as Amit keeps them calling, have reached here after intense competition. Firstly at the state level, then at zone level, now at the national level. So all the best to all the 16 people. May the all of you are winners for me. Thank you, Partha.
Thank you very much, sir. Namrata, a word from you, please. You unmute, please.
Thank you, Partha. Thank you once again, Scientific Committee, the entire members of the Scientific Committee, along with Partha, for having done this. I think for the participants, the most important thing is that you are today before an international panel, and that itself is a huge recognition for them, which probably they would not have got if Partha had not got the international judges here on the forum. So that is the accomplishment that is there today. It doesn't matter who comes first or who gets the prize or who doesn't get the prize. The fact that you're presenting in front of them, the fact that you're doing it with them is more important. The international judges, who are again well aware of the contributions of Indian ophthalmology by the virtue of presentations which we all do when we get a little older in various platforms. But I think today they have an opportunity to see also our young people, how they are going to be groomed up to become the talents that they are. Thank you.
Thank you very much, Dr. Namrata. Thank you. And now we have the pleasant opportunity to present to you Dr. Boris Maligan as one of the judges, Professor of Ophthalmology and Director General R&D at the Fedorov Microsurgery State Institution. Dr. Maligan is the president of the Russian Ophthalmological Society, European Society of Cataract and Refractive Surgeons, board member. Thank you very much, Boris, for being with us. I would request Dr. Sonu Goel to introduce Dr. Chi Sun-fek.
So it's my privilege to introduce to you this young magician, a great mentor, my friend, Professor Chi Sun-fek from Singapore, a professor at the National University of Singapore and the Duke National University of Singapore Medical School. She's a senior consultant and heads both the cataract subspecialty department and the ocular inflammation and immunology department at the SNEC. Welcome, Professor Chi Sun-fek.
Dr. Somshila Murthy, please, to introduce Dr. Elmer Tu.
Good evening, everybody. Although Professor Elmer Tu doesn't need much of an introduction, but we all know him as he's a professor of clinical ophthalmology. He's also the director of cornea services at the Illinois Eye and Ear Infirmary, Chicago. He has a vast knowledge and storehouse of infectious keratitis, as well as in the field of confocal imaging.
Thank you very much. Dr. Feroz, to introduce Professor Geoffrey.
Hi. Good evening, everyone. I am audible. So it's an honor and pleasure to introduce Dr. Jeffrey E. Rose, and fondly known as Dr. Jeff Rose. He has mentored many oculoplastic surgeons worldwide and is very well renowned in the field of lacrimal and orbital surgeries. And we have all grown up in oculoplasty reading his articles, his textbooks, and he is from Moorfields and he heads the oculoplasty in Moorfields. And it is a great honor to have Dr. Rose with us today. Thank you very much for accepting our invitation, Dr. Rose.
Thank you. Dr. K.P. Kudlu.
Thank you, Dr. Partha. It's my pleasure to introduce Dr. George Biko. He's a lecturer, University of Toronto, and also assistant clinical professor, McMaster University. His honors include being the Maiden Officer of the Most Venerable Order of the Hospital of St. John's of Jerusalem by Her Majesty of the Queen of England. I think it's our pleasure. George Biko is with us. Thank you, Partha.
Thank you very much.
It's a privilege for all of us.
Dr. Parikshit, please.
Yeah, thank you, Dr. Partha, sir. Dr. Lingam Gopal needs no introduction in India. Dr. Gopal has always been reticent and shy, staying away from the glare of publicity. But his voluminous work in research and clinical care is known all over the world. Though he spent almost his entire lifetime in Shankar Netralaya, he is presently a senior consultant, Department of Ophthalmology, National University Hospital, Singapore. He is, I think, a legend in retina. Welcome, Dr. Lingam Gopal.
Thank you, Parikshit. Dr. Batil Balla.
Yes, sir. It's my proud privilege to introduce our esteemed judge, Professor Jorge Rocha from Brazil. He's President Eye Retina Eye Institute and Retina World Congress board member, and also he's chair of RWCE Live from Brazil. It's our privilege and honor to have you with us to judge this prestigious show, sir. Professor Jorge Rocha. Thank you, sir.
Thank you, Balla. Dr. Feroz. Dr. Feroz.
Yes, Dr. Partha, thank you very much. Again, it's a privilege to introduce Dr. Kelvin Chong from Hong Kong. He's the Associate Director of Chinese University of Hong Kong Eye Center and the coordinator of Orbital and Oculoplastic Surgery Service. We have learned a lot from Dr. Chong as far as lacrimal surgeries are concerned. And once again, welcome. Thank you for accepting our invitation, Dr. Chong. Here we go. Thank you so much.
Thank you, Feroz. Dr. Amit.
Thank you, Dr. Partha. So it's my privilege to have Dr. Sean Yenchulev. He has a various numerous high impact contributions to the field of ophthalmology and vision science. And just to name a few, He developed the first virtual perimeter, the peristat. He was involved in the first antibody trial for Lucentis. He is the inventor of MeLoop, SciPass, and so on and on and on. So he has a lot of inventions to his credit. He's a professor of ophthalmology in New York Eye and Infantry of Mount Sinai, New York City, USA. So it's pleasure to have Dr. Sean. Welcome over here. Thank you.
Thank you, Amit.
Thank you.
And now we go over to the moderation, and you are the first moderator, Amit. Please go ahead.
Yeah. So our first presenter, the first young Turk to present today is Dr. Amrita Mohanty. She is a consultant in cornea and anterior segment services at Ali Prasad Eye Institute, Bhubaneswar. So over to you, Dr. Amrita. You have 4 minutes for your presentation. You will get the first reminder at the end of 3 minutes, and your final reminder will be at the end of 4 minutes. So once you finish your presentation, I'll be introducing the lead judges to take the questions to start the discussion, and any other judges, if they also want to ask the questions, they can ask. So we have our admin over here, Mr. Sunil, who's going to monitor the presentations of all our young Turks. So the first call will be allowed by Mr. Sunil at the end of 3 years. The final call will be at the end of 4 minutes, 3 minutes and 4 minutes. And all our judges are supposed to evaluate all the young talents. The Google mark sheet has already been sent to you, and we request all of you to please evaluate each and every presenter. Thank you, and over to you, Dr. Amrita.
Yeah, thank you, Dr. Amit. Is my screen visible?
Yeah, your screen is visible.
Yeah. Good evening, everyone. In the next few minutes, I shall be describing a novel corneal epithelial entity which I encountered in a fine morning of June in my OPD. Okay. So it was a very new looking corneal epithelial entity which bewildered my neurons. He was a 30-year-old male with history of pain, photophobia, foreign body sensation in his left eye for last 30 days. He was treated with topical ganciclovir for viral keratitis by the referring ophthalmologist. There was no predisposing risk factors, that is, there was no foreign body, no exposure to trauma, toxic substances, or any use of contact lens wear. There was moderate conjunctival congestion, and the cornea revealed a superficial grayish-white raised epithelial lesion, which is well demarcated, amoeboid in shape, punctate fluorescent staining positive, and the rest of the cornea was absolutely normal. That was, there is no edema, infiltrate, or vascularization. The tear film height, corneal sensation, lid margins, and lid apposition blinking rate were normal. Luckily, this patient was seen in 2017 by one of my colleagues, and the clinical appearance had an uncanny resemblance to what we have seen in 2019, but present at a different location. Corneal scraping was repeated twice and revealed no organism, and the patient was treated with topical lubricant and antibiotic. The lesion kept on changing its shape with every rescraping, with a centripetal resolution with a clear cornea at the end of 6 weeks. Coming back to the same case, in 2019, we also scraped the patient thrice, and we didn't get any organism on 3 separate occasions. The lesion again kept coming back. We started the patient on topical antibiotic and lubricant. And the end of the 3rd week, we did an epithelial debridement because it was obscuring the visual axis. And to our dismay, as soon as in a week span, it recurred beneath the bandage contact lens, and it started progressing centripetally. But fortunately, it resolved with a clear, almost clear cornea of the fence scarring at the periphery at the end of 3rd month with topical lubricants alone. The first common differential which came into our mind was OSSN, which was ruled out by histopathology in our case, which revealed squamous metaplasia and keratinization and discohesion. There was no presence of any cytological atypia, any deposit on special stains, infectious organism, or signs of inflammation. A-society again was not corroborative of OSSN. HSV was ruled out by doing a PCR, which was repeated thrice. Other coarse epithelial lesion and systemic association were also ruled out. We had a déjà vu experience when we saw our second case after 3 months, which has a very similar similar lesion, and we did a scraping. Again, it was negative, and we did an epithelial debridement early in this case, and it healed with the peripheral scarring at the end of 2nd month. So we were dealing with possibly new entity. The first term which came into our mind was migratory epitheliopathy of unknown etiology. But as the etiology will be unraveled someday, we changed to the term migratory serpiginous corneal epitheliopathy. We discussed this among our peer group, and these are the two cases which has the closest resemblance, microbiologically negative and responded to epithelial debridement and antibiotic. We collated these 4 cases and published in the esteemed Ocular Surface in the last month. Journey so far of MSc was not very easy, right? We had literally sleepless night dealing with the first case, chasing the etiology. And also we had a difficult time with the reviewer convincing that it is a possibly new entity, but the etiology is not known. The motto of describing such a cluster of 4 cases only in such a huge podium is to take this entity as far as possible, because what is known isn't, it is possibly a new entity, but the etiology is still to be deciphered. It do recur, but we exactly don't know the nature and course of the disease. Although the first case has been followed up with 1.5 years with us with no free recurrences. It do respond to epithelial debridement, but the gold standard will obviously depend on the etiology. So I still, yeah. Thank you for a patient hearing.
Thank you, Amrita. So we have our lead judges for your presentation, Professor Elmer Tu and Dr. George Baiku. So over to you, Professor Elmer. We start today. We'll open up the discussion with you first.
Good morning, Dr. Amrita. Thank you so much for this wonderful presentation. What a way to start us off today. It's wonderful. Exciting. I've seen this, I've never seen anything like this specifically, but in looking at this reminds me of, epithelial replacement after limbal stem cell transplant, for example, or the sort of migratory nature of it is a Lisch dystrophy. What is your hypothesis as to what the origin of this is? I mean, there's certainly, you've looked at nutritional, but genetic, is there any link that you've seen between the patients, or any seminal events, nutritional events, or trauma or exposures that might link the 4 cases that you have?
Thank you, doctor. Actually, all the 4 cases were young patients who couldn't illustrate any of the evident predisposing risk factors. But what hypothesis can be put looking at the clinical picture and nature of the entity is that it may be an abnormalative reparative process, somewhat which is seen in a wave-like epitheliopathy. Keeping in mind the XYZ hypothesis, the Z component is impaired in these cases. That is, the epithelial loss is not equivalent to X plus Y. So some insult to the limbus, or like a temporary insult to the limbus, maybe.
And just a final question for me is that, have you thought about biopsying the limbus from where this is originating, or is that something that's impractical for these patients?
Actually, we have taken the debridement from the lesion only. We have not looked into the limbus. The lesion fortunately didn't recur after that. Possibly, maybe in future cases while dealing with that, we can keep that in mind.
Very interesting. Thank you, Dr. Amrita.
Thank you.
Over to you, Dr. George.
Thank you very much. A very interesting presentation. My question to you is, why did it take so long for these patients to present to you, number one? And number two, when I look at it clinically, it's the thing that it's most reminiscent to me of, although the location's not right, is that of a shield ulcer. So there, it's trauma that's actually causing that that situation to occur. Is there any history of eye rubbing or trauma in that sense in these patients?
No, doctor, no, any such risk factors were not present. And regarding presenting very late to us, all of the cases were interestingly treated as viral keratitis and were on ganciclovir. I don't know, it might be something like hurricane or vortex keratopathy following exposure to drug toxicity. All of them had exposure to ganciclovir and treated as viral keratitis. There was no signs of any allergy or atopy.
Thank you very much.
Yeah, thank you, Dr. George. Any of our other esteemed judges, do they have any question for Dr. Amrita? Any judges? Anybody wants to pass a comment or any suggestions? So, okay, fine. So thank you, Amrita. So we end your case here and we proceed to our next presentation, which will be by Dr. Aniruddha Agarwal. And I invite Dr. Feroz to take over the next presentation. Over to you, Dr. Feroz.
Thank you, Dr. Amit.
Dynamic Scientific Committee member.
Thank you so much. It is, can I have the slides? Yeah, thank you very much. And it's a pleasure. And I'm very happy to introduce Dr. Aniruddha Agarwal, who's a very young and competent doctor in the specialty of vitreoretina and uveitis. He is the assistant professor at Postgraduate Institute of Medical Education and Research at Chandigarh, India. And he has won numerous awards, and there is a list of publications and research that he has already, been part of. So over to you, Dr. Aniruddha, and all the very best.
Good evening. Thank you. At the outset, I would like to thank the Scientific Committee and Governing Council of AIOS for this opportunity. And just like to confirm if my slides are visible.
Yes, they are.
It is visible and you're very audible as well.
Thank you. So it's my privilege and honor to be here in front of such an elite panel, and I'll be discussing what retinal imaging holds for us in 2021. Over the past 2 years, my research has primarily focused on two aspects: differentiating and diagnosing uveitic entities and quantifying the lesions. And I've had two goals. One is using simple imaging available to all of us as clinicians, as well as complex tools such as OCT and OCT angiography to get answers in the clinic. My second goal has been to establish collaborative research consortia globally. None of my research has been funded, or I do not have any financial disclosures. Moving on to my first area of interest, and this is tubercular serpiginous-like choroiditis, a condition which is endemic in a country like India. What we've done is we've used simple observation and a fundus camera to classify lesions into 3 grades. And this is based on the opacity or yellowness of the lesion. And we realized that lesions which are grade 3, more opaque, more yellow, had a high tendency to progress and develop paradoxical worsening. These results were published in American Journal of Ophthalmology this year. Now, what we've done is we've furthered this research and tried to develop, we failed several times initially, but now we've been successful, partly at least, in developing automated algorithms in identifying the choroiditis lesions, and with the goal to make inflammations not so intimidating. The idea is to use simple third-party softwares available to all of us and run automated algorithms to be able to identify choroiditis lesions. So it could be TB in India, it could be MPE or multifocal choroiditis in the US, for example. And we develop these algorithms for convoluted neural networks in artificial intelligence. Now in India, we see patients of TB serpiginous-like choroiditis day in and day out. And we image them using fluorescein angiography and ICG. And in the past, we have shown using OCT angiography how the choriocapillaries ischemia correlates exactly with the ICG imaging. And these results were published in Retina in 2017. In 2020, I have furthered this research and have used prospective studies to evaluate these patients further using OCT angiography. And we realized that lesions which are very small on the OCT angiography have minimal residual disease when they heal on the choriocapillaries. And in fact, you can now use OCT angiography to follow up these patients and do not have to rely on invasive imaging. And our goal now is to make all of this automated so that it's available to all of us and we can quantify and follow up our patients. These results were published in Retina in 2020. My another goal is to use OCT to differentiate difficult entities. And these include toxoplasmosis, viral retinitis, and lymphoma. We know that using very simple clinical clues like cells, the stalagmite-like deposits, or choroidal lesions can point towards diagnosis such as toxoplasmosis. Of course, lab findings are paramount, but we can identify these very small points and develop protocols which can be integrated into artificial intelligence methods. This was published in British Journal of Ophthalmology in 2019. Since 2015, I have been a part of a number of study groups, such as the Collaborative Ocular Tubercular Study Group, the PGI Lymphoma Group. But more than anything else, I think what I've developed is a lot of friendship and collegiality with friends all around the globe, and I think I'll cherish that forever. With this, I'd like to once again thank the AIOS Scientific Committee for this opportunity. Thank you very much. Jai Hind.
Thank you, Dr. Aniruddha, for an excellent presentation. So may I request our lead judges, Dr. Lingam Gopal and Dr. Rosha, may I invite Dr. Lingam Gopal to initiate the discussion. Over to you, sir.
At the outset, I'd like to congratulate Dr. Aniruddha for his excellent presentation. It's really a voluminous work, and I'm sure this 5 minutes was not enough for him to present to us exactly the crux of the story that is constructed by using OCT and OCTA for investigating various uveitic entities. I just wanted to ask him one question. If there is one condition where can you label where OCT and OCTA can be actually misleading rather than contributing to your management plan?
So we actually, very interesting question, sir. Thank you for that. We were recently studying patients of TB choroiditis with paradoxical worsening. And we realized that OCT and OCT angiography can actually sometimes mislead in these patients. And these patients can progress to develop blinding complications because you are able to see a healing pattern of what is called as a middle limiting membrane. These patients, when they heal, there is a layer of the inner plexiform which atrophies and becomes a very thinned out layer, which exactly corresponds to the Zimmerman's layer, which he has described back in the 80s on pathology. So if you solely depend on OCT and OCT angiography, you're going to miss the bus. And that's why it's very important to see these patients in totality. And of course, if you have peripheral lesions, if you have a retinal vasculitis, if you have diffuse pathologies involving the sclera and other aspects, you have to see everything in totality and just not depend on OCT and OCT angiography. And one very minor point is viral anterior uveitis. These patients can have OCT findings of the posterior segment, but does not necessarily mean that they have posterior segment disease. So that could be another point that we must take care of.
I think it's a very, very important point. You stress that it should be taken in total, the whole picture, and not just depend on OCT or OCTA, which is of course applicable to any disease entity, but very rightly emphasized. Thank you.
Thank you.
Thank you, Dr. Lingam Gopal. May I request Dr. George Rosha to take the discussion forward? Over to you. Thank you.
Hi, everyone. I'm very pleasure to listen so distinguished talk. I'm really impressed, and I'm just thinking many things. And just one point that's to understand well. You are trying to create algorithms for artificial intelligence to provide us better diagnosis, differentiates entities like lymphoma, tuberculosis, toxoplasmosis. And what information that you are providing these algorithms to have the results, the differentiation in the other part of the end of the process?
Thank you for the question. So just to clarify, we have been using artificial intelligence protocols. We are really in the infancy and have only reached up so far as to TB. We have not yet gone into the area of lymphoma. But the idea is to look at the minute details. The beauty is in the details. So if you can pick up certain clues on fundus imaging and apply them in protocols, then maybe you're able to identify or differentiate certain conditions. So for instance, like I showed you, in toxoplasmosis, you have choroidal involvement and you have RP involvement. Whereas in a lymphoma, you will not have a choroidal involvement. So it is possible that in addition to your lab parameters, you can apply these imaging parameters into algorithms, which may be much more detailed. We are really at the infancy, and develop these diagnostic tools so that you can develop a clinical score that actually makes you aware. It may not provide an answer, but it makes you aware that you have to consider a possibility of an alternative diagnosis. So I think that's so far as the artificial intelligence is concerned. Ultimately, it's the human intelligence which will work. But these are just very few baby steps in the direction that we have been taken. And once again, we've just reached up to TB so far. I think it's a very, very long journey ahead.
Congratulations.
Thank you.
I love the idea.
Thank you, Dr. Rosha. Do we have any other judges who would want to ask questions or lead the discussion? Anyone?
Thank you. Then we shall go over to our next presenter.
Dr. Gunjan Saluja. And may I request Dr. Balla to introduce Dr. Gunjan?
Yeah, it's my proud privilege to introduce the next participant, the young and dynamic Dr. Gunjan Saluja. She's done her post-graduation from prestigious RP Center, where she is working as senior resident in the field of strabismus and pediatric ophthalmology. She has done her DNP and fellowship from International Council of Ophthalmology in the field of pediatric ophthalmology. Over to you, Dr. Gunjan Saluja, for your presentation. And the lead judges for this are Dr. Sean Ianchulev and Dr. Boris Malugin. Dr. Gunjan, please.
Thank you, sir, for the kind introduction. I'll start sharing my screen. So, a very good evening, everyone. I'll be presenting my work, which has been done for the wet lab training models for residents during COVID-19. Surgical training, as we know, is of the utmost importance in the ophthalmologist. And but however, with the rampant of COVID-19 cases, the routine surgical procedures have come to a halt, and this has affected the surgical training the most. And so our aim was to perform and practice the maximum surgical procedures on an animal eye model, besides the conventional cataract surgery, and to develop a new indigenous do-it-yourself model to practice the basic steps of cataract surgery. Goat's eyes are, so coming first to the animal eye models, we usually have goat's eye in our center. So these are easily available, inexpensive, and can be bought from the local slaughterhouses. When they are mounted on the mannequin head, a large number of surgeries can be performed besides the cataract surgery. These are the corneoscleral perforation repairs, recession, resection, and plication surgeries for squint, buckling surgery for retina, and also one can perform trabeculectomy with releasable sutures using this goat's eyes. However, during the COVID-19, there were some days where the goat's eyes were also not available. And for this, various models were being used like phaco eye and Kitaro eyes. But the disadvantage was that they were not cost effective and they were only for single use. Hence, we designed a cost-effective do-it-yourself model using a rubber ball in which first the crater was created using a sharp-edged instrument or a knife. Following that, the lens was made. This lens is made with the combination of 2 spoons of corn flour, 2 spoons of water, that is in equal amount, and a drop of glue. All of them, when heated for 2 minutes, forms a dough-like consistency, which is then made a nucleus. Cornea can be obtained either from the discarded phaco eyes, if your wet lab has one, or can also be obtained from the bottle of the nipple of the milk bottle, as is being shown in the video. After that, the nucleus is placed and the cornea is fixed. The nucleus is of intermediate hardness, as is shown here. And the cornea is fixed with the help of fevi-glue. And after that, various steps of cataract surgery can be performed, like sculpting, as is shown in this video. A trench is being created. And one can also practice chopping technique using this model. After that, intraocular lens implantation can also be done in this model. This provides the residents the proper hand, foot, and eye coordination and the first feeling of going inside the anterior chamber. After this, the residents were provided with questionnaire, and obviously the handling appearance with the human tissue was quite different, but they did find an increase in their confidence, and they did help them into performing sculpting and chopping. So wet lab models are cost-effective and simple way. They help to gain confidence, and it's a cost-effective model and can be used to practice various steps of cataract surgery. Thank you.
Yeah. Now I would like to invite Dr. Sean Ianchulev to start the discussion, and you can question Dr. Gunjan Saluja, sir.
Thank you. And wonderful presentation. Actually, a pretty significant problem when it comes to training. We're still struggling not only for an effective, but also a cost-effective way to do that. In fact, here we started out the robotics program at New York Eye and Ear, and we've done this with, for example, with the MyLoop. It's always been challenging to find a very good reproducible model. So very, very fascinating. Definitely on a shoestring innovation, but that's how some of the great ideas come out. One of the things that I wanted to understand a little better is obviously, when we do phaco, one of the main concerns is posterior capsule, or also being close to the cornea as well. How does that model perform in terms of giving guidance whether you are operating or the operator is close to the posterior capsule or threatening some of those tissues? Is it easy to tell that, or that's a little challenging here?
Definitely, sir. This is a challenge in our model. This is actually one of the limitation of our model, that we cannot practice capsular access, and that posterior capsule is also not there, which is an important push part. But one can definitely develop a hand, foot and eye coordination. It is important for the beginners to actually begin having that hand, foot, eye, ear and tactile coordination while they are beginning with their cataract surgery. So this model is mainly designed keeping in mind those first and second year residents who are beginning with their cataract surgery training in the initial days. Definitely, we will look forward, and we are designing for a model which will have a posterior capsule like structure also.
Right. Okay, great. And one other question in follow-up. Obviously, for anything that is innovative, step one is important, but you have to take it to the next step. As an innovator, what is your next step? How would you improve what you currently have, which is great beginning point?
Yes, sir. The second, what we are thinking the next is, first we can use them for the larger number of residents. Now we have done the study only on 15 residents, so we can provide them on for more number of residents. And second, we can instead of using the rubber ball, we can also use a plastic ball, and then we can try using covering the nucleus in a plastic wrapper, or giving a posterior capsule-like feel. Which, and then basically our next aim is just to have that posterior chamber feel, and how does it feel when the nucleus goes back, and how to manage the anterior chamber pressure changes while operating.
Wonderful. Thank you.
Thank you, sir.
Now I would invite Dr. Boris Malugan. Sir, you are the second lead judge for this presentation.
Thank you, sir. First of all, I would like to congratulate Dr. Saluja with the innovative way of thinking of producing this eye model with some kind of, things that are under the hand. That's really a good improvement. There was a brief discussion about the next steps. And obviously, I think it would be a good idea to have further steps in the direction of commercialization of that product, which I believe will be very affordable. And basically, what is needed here, probably the idea how to integrate the capsulorhexis step, because we know that it is also a very challenging step for the residents. And I believe a training and cost-efficient training to that step of the procedure might be critical. So my suggestion for you to think as the next step, how would you try to replicate anterior capsulorhexis step of the phacoemulsification procedure in your model? And I believe you will be able to do that. And also the next probably step of improvement will be to have nuclei of various density. That might be also a good idea to have. So I think it's a lot of things that you can do in the pipeline. And my suggestion for you not to stop at that point, but rather go forward and to master your technique and do that in the way that it will be available at some point for the other residents, for the other clinics.
Thank you, sir. We'll surely keep these in mind.
Any questions or comments from any other esteemed judges, sir? If not, then I would invite my dynamic scientific committee friend, Dr. Krishna Prasad Kudlu, to take over from here. Dr. Kudlu, please.
Thank you so much, Balla. I think it's my pleasure. Davis Akara, he is a faculty in the Department of Ophthalmology of Sri Ramachandra Medical College. He is also formerly glaucoma consultant at Little Flower Hospital, Angamali, and also Western Eye Hospital, Cochin. The lead judges for this particular presentation is, once again, I request Dr. Seen Lanchlow and Dr. Boris Malijan. So before that, I think I just hand over mic to Dr. John. You can continue.
Thank you, sir. Thank you so much. Let me start sharing my screen.
Can see, you can go ahead.
Yes, sir. So let me start.
Yeah, please.
Okay, my presentation is about the smartphone portable eye clinic system, which I call as SPECS. So smartphone portable eye clinic system, what is it? It is a set of do-it-yourself smartphone-based and portable devices for eye doctors on the go for detailed eye examination. And let's first look at an unboxing video. What does it contain? So it contains two smartphones. We'll open and show you. And it contains one tablet PC. And it contains something I call an eye ruler, which is a scale with printed on paper, two lenses, 78 diopter, 20 diopter, a red blue anaglyph glasses, a slit lamp adapter, universal adapter, what I call a Keracan mini topographer, which I made, a virtual reality headset, an empty plastic bottle, a do-it-yourself smartphone slit lamp. So these are things which I'll be using. This is the general flow of a routine ophthalmic eye examination. Let's look at each in detail. So first is history taking. For history taking, we can use smartphones for virtual history taking, especially in this time of social distancing. I have made a few apps, the I Know Tamil and I Know Bangla apps for doctors who don't know the particular local language. This is a handbook for that language ophthalmic terms. Then you can use apps such as the pulse rate measurement app and the respiratory rate app. These are not made by myself, but these are available on both the Apple and Android Play stores. And you can use it for vision testing. You have the iChart Pro and the Peak Acuity apps available, which can be used for vision testing in smartphone. And these are calibrated according to the screen size. You can use even binocular stereo acuity testing by using a Randot stereogram testing app and using the red blue anaglyph glasses, which I showed earlier. We can do smartphone refraction. These are a little more expensive. These are IQ and iNetra, made from technology from MIT Camera Culture Lab. This is something which I made, which is a printed scale which you put in a photograph to measure things. We use the app called Image Meter to calibrate the scale and measure. Then there is the iTurn app for the Hirschberg test, the iTilt app for abnormal head posture, and the 9-gaze app for 9-gaze photographs. Then for slit lamp examination, I made something else, which is a portable slit lamp made out of 3 sample collection bottles, a white LED, a 9-volt battery, a slit which I made out of cardboard, and a focusing lens, which is a 78 diopter eye examination lens. I'll show you how it works. So if you look at this particular examination, you can see the slit on the eye. You can see the layers of the cornea and also into the anterior chamber and the lens. So this is very useful rather than just a diffuse illumination with a torchlight. Then I have the plastic bottle fundus camera, which is a plastic bottle with a smartphone at one end held with the adapter and a 20 diopter lens, which can be used to take smartphone fundus photographs. I think all of you must be familiar with this technique. I have been one of the people who did one of these models. Then another thing is the Keracan Mini Top, which is a Placido-based topographer, which I made, which is how you get the images is you get videos from the smartphone and you get the reflection of the Placido's rings on the cornea. And this has to be analyzed. I haven't got to that part yet. So then there is a virtual reality perimetry, which I think Dr. Sean is familiar with. I did this while I was in Arvindai Hospital, Pondicherry. So all these things together will consist the smartphone portable eye clinic system, which fits into a suitcase such as this. So you carry this around and you have your smartphone portable eye clinic system. Thank you.
Thank you, Dr. John Davis. I think to start with, the lead judges are once again Dr. Sean Lantlew. I think I request him to start with the discussion.
Thank you. Thank you. Wow, how fascinating. I think in these pandemic times, we're all really pressed to start traveling. Now that looks like the perfect solution for the traveling ophthalmologist. So congratulations. It's a lot of work. It seems like it's a great potpourri of innovations that you've tried to package in a kind of a traveling embodiment there. One of the things, and I'm familiar with some of the apps, obviously you're using a lot of technologies that you're bringing from different innovations or other collaborations or even commercial systems. One of the things that I hadn't seen before was the slit lamp. And
I made that.
Slit lamp is always a problem. And so I appreciate actually this is your own innovation as part of the suitcase.
Yes, sir.
Tell me a little bit or tell us about that. What can you not see with that slit lamp? Because obviously a slit lamp that we can take on the go in a cheap and easily deployable way is excellent. But I also would imagine there's some limitations. Tell us the limitations of that slit lamp device you have.
Yes, sir. So the slit lamp, which it essentially is just a slit lamp. It doesn't have the optics to view. The optics which I would use as my own eye, so there is no magnification. And if you want to use magnification, you could use a smartphone, but then that becomes a monovision. You would not have stereopsis. So ideal way to use this is perhaps when you are on duty, when a postgraduate resident is on duty and you have to examine a patient somewhere, you take this in your handbag and you turn this on, you get a light which can be focused. So this is just a series of tubes. This is a series of sample collection bottles with a slit in the center. In this place, I have put a black slit, which is focused using this lens. So this is a MacGyvered slit lamp, which I made out of sample collection bottles.
And I assume you cannot see really cell and flare.
Cell and flare,
can you?
Cell and flare, if it is more, you can see it. If you have, say, 3 to 4 grade of cells, you can definitely see it. And if you look, you have to go a little close to the patient for that, but you can definitely see it. You cannot see mild.
No, very fascinating. And congratulations. This is not easy. And you're doing a multitude of things. You're packaging them. And I think it's one other part that shouldn't be missed is as you package those technologies, you're obviously evaluating which are the best ones for the purpose, because there's gonna be, and there already are so many that a lot of us don't have time to evaluate any one of them comprehensively. So finding the right ones that are more validated and that work is great. But more importantly, keep working on your own one, which you're inventing, because there is a big need for that. And I congratulate you for trying. Again, step one that you need to take to the next level.
Yes, sir. Yes, sir. So this is necessity is the mother of invention. So because of this COVID pandemic, we had to find ways to distance ourselves from the patients, bring about safety parameters. That is one of the reasons why we ended up using these things. Thank you, sir.
Congratulations. Great work.
Thank you, Sean. I think I request our friend, Dr. Boris, to give his opinion. Comments,
yeah, thank you. I also enjoyed this set, which was very practical and looks like simple but very, very, very practical thing. So what was I mostly interested in is that the fundus pictures that you are taking with the help of the plastic bottle. Can you explain a little bit in more details? You was using I believe midriasis, plastic bottle, and iPhone.
Yes.
So these are kind of combination. So and this plastic bottle helps you to keep the perfect distance or to avoid any side images. So what's the rationale of using that?
Yes, sir. So there is this method of smartphone fundus photography, which I routinely do. I was taught by Dr. Biju Raju, and I think so many people are doing this. It is you use a 20 diopter lens and you use your smartphone with the camera flash on. And if you focus precisely, you can get fundus photographs, fundus videos. We prefer to take fundus videos. And I have published articles on that. I have published in IJO about a device which we made with a PVC pipes to do the same thing. And then we thought, why do we need to go to the hardware store and get PVC pipes when we have plastic bottles all around? So one of the students who came to me in Arvind Eye Hospital, I told him we should find a better way, and we put together a plastic bottle, put the phone and the lens on either end so that it becomes a rigid body, and you have to hold only at one point. You have to hold just with one hand, whereas the other hand is now free to examine. So we get excellent fundus videos, and we need mydriasis. Only on a mydriatic eye, you get this slightly non-coaxial light going into the eye and getting the image back.
And I believe probably the distance and the longevity of that pipe or bottle might be critical. So how would you select the size of that device?
Yes, sir. Surprisingly, it is not as critical as we might think, because all modern smartphones have autofocus. So because of that, from 15 to 25 centimeters, it practically focuses by itself. We can always adjust with the manual focus option in all these modern smartphone apps. So we tend to use the autofocus, a touch to focus on. When you see the retina on the focusing, we touch to focus and lock the focus. And once you lock the focus, then you can actually take a full fundus video, and that works out pretty well.
Excellent. Congratulations. Yeah, very nice. Very nice too.
Thank you. I think it was really wonderful discussion. I think let us go into the next introduce. Dynamic Scientific Committee member, Dr. Parikshit Gopal. Over to Dr. Parikshit.
Yeah, thank you, Dr. Kudlu. Dr. Nivian is an academic director of MNI Hospital Private Limited, Chennai, and he has been the first to perform live 3D cataract surgery in South India. He's a specialist in MICS 1.8 mm phaco for cataract and MIVS 23G vitrectomy for retina. Today, he'll be presenting CMT-Flex IOL, an innovative alternative for spherophakia. And for lead judges, we again have Professor Boris Malugin and Professor Chi Sun Peck. So over to you, Dr. Nivian. Please stick to your time. I mean, your presentations are fantastic, but just be special with the time.
Thank you, sir, for this kind introduction. Just sharing my screen now. Yeah. So respected teachers, senior ophthalmologists, my dear friends. So I'm going to talk about my innovation, the new CMT Flex IOL, a new option for the treatment of aphakia. I do not have any financial interest. So this is a case of a 360-degree subluxated lens planned for a lensectomy, vitrectomy with a scleral fixated IOL. So as the question arises, why this new invention? That is how my journey started 2 years back, when all the available scleral fixated techniques were the SF-IOL technique with the suture, which is time tested and proven. And then came the modified Amar Agarwal's glued IOL technique, where the haptics were externalized and tucked in the chariot's pocket. And then the few modifications by Arvind to externalize these haptics using the needles, and the emanate techniques of cauterizing the tips so that they did not fall back inside. But these were all modifications of the existing 3-piece IOL. So that is when the idea came, why not have a new specific design of an IOL for these types of aphakic patients? So let me just go through my surgical case. For any scleral fixated IOL, we all know that the marking of the 0-180 degree is very important for 2 reasons. One, for the centration of the IOL, and also for the rotational stability of the lens. So here we make a 2 by 2.5 millimeter partial thickness scleral flaps using a crescent blade, which is done on either side. Measuring 1.5 millimeters away from the limbus, a 23 gauge needle is used to make a sclerostomy, which is also done on both the sides. Now here, because we have a lens which is dislocated, I'm using the 23 gauge needle to pierce into the lens and stabilize the IOL. And being a VR surgeon, I know how difficult it is when it falls back inside. So I'm using the second sclerostomy for my cutter, going in and doing the lensectomy. So just making a hole at the posterior thing and using a combination of cutting and suction, making sure we do not lose any fragments posteriorly. And since it was a soft cataract, I think there was no trouble in removing the entire lens in toto. So this is the new lens. It's a single piece hydrophilic lens with a specialized T-shaped haptic that you can see here on the screen. So this was the new foldable lens that can go through a 2.8 millimeters clear corneal incision. And these are specialized T-flex forceps that have a small broad tip because these lenses, when you hold it and grab, should not chip or should not have any impression on them. So holding the neck or the head of these IOL is first done. And at this point, we do not pull the lens. Now the entire lens is injected into the anterior chamber, making sure the trailing haptic is kept at the section or over the iris. And once that is done, we can pull the haptic out and you can see a pop of the T-flex. And once it comes out, it opens out and that's it. That prevents the thing from falling back inside. So that is the whole concept of this new IOL, that the T haptics. So this is just a small animated video clip. Make sure the T haptics is coming out first. So this makes it easy for us to grasp. And this goes into any normal cartridge. So you can see the head can be grabbed and then pulled outside through the sclerostomy. And once it comes out, it opens and that prevents it from falling back inside. The other side, using the handshake technique, is exchanged to the other side. Here again, you can see holding on to the head is grasped and brought out to the other sclerostomy. This literally is the end of the procedure because the centration is there. They have these large 6mm optics. So we just remove the trocars and we can use glue to cover the scleral flaps and the conjunctiva, or sometimes we can even suture them. And these are some of the post-operative pictures on day 1 and day 30. And we have studies on the UBM to show the position of the lens because we are given a small angulation between the optics and haptics. And we have a 2-year follow-up. So we have some of these publications. I'm happy to announce that the recent one has come in JCRS in November about these lenses. And thank you once again in this COVID times. I think we should all stay positive in our thinking and COVID negative. So thank you once again for the entire AIOS team and Partha sir for this wonderful opportunity. Thank you.
Thank you, Dr. Nivian, for
we just lost Parikshit, I think. So we'll ask Dr. Boris Maligan.
I would request Professor Boris.
Carry on, Parikshit.
First of all, I must say that it's a very interesting lens model. And I believe that we would like to go away from the sutures because we know that the suture fixation of an IOL to the sclera is challenging. And in many cases, these sutures can biodegrade, with the minor exception, such as Gore-Tex, which is not very available in all of the countries. So by utilizing the haptic fixation to the sclera, I believe it's much more reliable. The design of that lens looks quite similar to me to the lens called Carlevale lens, which is made in Italy, and sharing the same concept of the T-shaped haptical element, although with some design variations. So, and I think that it's very critical to have this flexible haptic mechanism that helps to adjust to the size of the sulcus, to adjust to the different sizes of the sulcus that we can see in different eyes. So my question is to the inventor, to Dr. How challenging is that to grasp the second haptical element to introduce into the sclera?
Thank you, sir. Yeah, the second haptics, we use the handshake technique, and we also designed 2 specialized forceps for this, because I said being a hydrophilic lens, one, we need a good grasp. So the grasping forceps has got some crisscross serrations so that it helps you to grasp it without slippage, and also should not have any marks on the IOL. And the other T-flex forceps has got a small broad tooth at the end so that it has a firm grip but does not chip away the lens or bite through the lens. And I also accept your this thing about the Caravelle lens. During our journey after 1 year, I came across his talks, and I also saw his videos. So there are a few, as you had already mentioned, a few small differentiating features in the design technique. And we also have a small angulation between the optics and haptics, a 10-degree angulation, so that it does not rub against the iris when there is a movement of the pupil. Thank you.
Thank you, Dr. Nirian. Professor Chi Sun Pa.
Ma'am, your audio.
You're mute.
Congratulations on your presentation. I have a question regarding this lens. Is there, because of the design of this lens, do you think there's a need to actually size the lens? Because if you have to deal with a myopic eye, you know, that length of your haptic to haptic being 13 mm may be a little short. And how thick is that T haptic? Is there a chance of extrusion over time through the scleral flap? And I also have, you know, questions regarding how easy is it to grasp that haptic, because I'm just concerned that, you know, when I saw the forceps, it might actually rip through the hydrophilic material. Have you had any break in your hands and slip back into the eye?
Thank you, ma'am. Going to the first question, as you said, right now we have one standard size. The overall size is 14 millimeters. So we can do it for normal eyes. What we suggest for the smaller eyes is we can make the sclerostomy 1 millimeter further away from the limbus. We can go up to 2.5 on either side. So that helps. But as you said, the large eyeballs are sometimes challenging. So what the company says is they can make customized lens once we have a set normogram that we define. So measuring the white to white, and if we can give them the thing, they can make the size available. So that is for the first. So right now we have only one standard size for the common eyes. The second part of the question, yes, initially I was using the retina forceps that was available, and I did have these problems of chipping away of the lens and breakage of the haptics. So that is why we came up with this specially designed forceps used for this. So it's slightly broad and flat, but it's got some grip. So in this, I have not had any problems as such. And as sir has already mentioned, it's a single piece lens, so there's no junction, and it is slightly stretched. The model from the optics to the haptics, we are given an arm. So that arm actually helps in the stretchability of the lens. So there is some amount of stretching that happens that helps in preventing it from tearing away. In the initial design, we had these problems, so we had to overcome with the new design later on.
I had another question regarding the haptic, whether there's a chance of extrusion or exposure, because being hydrophilic material is quite thick.
Correct. So that was also what we are doing. Right now, we have only 2 years follow-up, and only one case we had an exposure through the, because we're doing it under the scleral bed. So we are just studying an OCT cross-section to see how the reactions are. Right now, even I don't have the answers for more than 1 year follow-up of what is going to happen. So I think I'll have to wait for the results to come up with that answer. It's a good question.
Thank you.
Thank you.
May I add one more question? So we know that with the scleral fixated lenses, sometimes the tilt is critical. So how about that issue? Does your lens design solve that issue? And I believe it's it should be done by kind of, you know, modeling the T-shaped part. It should be longer or more stable. So how do you address the tilt of that lens?
Yeah. So initially, to get it out of the sutureless technique, so we had to do it out of the 23, so it was slightly thinner. So at that time, there was some amount of rotation seen. So we had to measure the sclerostomy size and make sure this is adequately snugly fits inside, so that there is no rotation of the lens after we place it. So now, right now, what design we have is, so we have not found out any rotation that has happened, but the 0-180 degrees again seems to be very critical and a very crucial step.
Thank you. Thank you, Dr.
One small question, can I ask?
Yes, sir.
Yes, sir.
Yeah, I'm Lalit Verma. Yeah. So this is the same as what Boris was asking. Tilt is a major thing, but donosis, you see, the pseudo-phacodonosis, because whatever you may do, the snug fit of this, you know, may not be always there. You see, one odd case may be there, but generally there will be a disparity between the size of the haptic and the sclerostomy. So there's some donosis disturbing maybe there.
Correct, sir. We are trying to, so initially it was thinner, sir, to get it out of the 23. So that time we had this issue. So we had to make it, and sometimes if it goes thicker, it is sometimes difficult to come to the sclerostomy. So that is when it used to chip away. So measured in such a way, it easily comes out of a 23 gauge sclerostomy. At the same time, it does not move. But as ma'am said, I think we'll have to wait for a longer, we have 1 year follow-up. We'll have to wait for a longer follow-up.
Concept is
May I ask one question as well?
Thank you,
oh,
sir.
sorry.
Yeah, yeah, sure.
Yeah. Would any other panelist or a judge want to ask question for Dr. Nivian? Because, I mean, there are so many options for the management of aphakia, and I think the jury is still out as to what is the best one.
I do have one question. Is with the externalization of this, I mean, rather large nub, is there an issue, or have you encountered any problems with leakage or hypotony afterwards?
No, sir. That particular thing we have not come across any leakage or hypotony. We have not come.
Right. Thank you, Dr. Nivian, and thank you, Professor Malignan and Professor Chisun. I would now request my learned scientific committee member, Dr. Somashila Murthy, to take over.
Good evening once again. It's once again my pleasure to introduce the next speaker. The next speaker is Dr. Nilesh Kumar. The lead judges for his presentation will be Professor George Beko and Dr. Sean Eanchule. Nilesh has done his MBBS from Kasturba Medical College in Manipal and his ophthalmology from Jain Medical College in Belgaum. And he's a very young final year resident doing his residency at Lotus Eye Institute in Coimbatore. I found that when we were going through the semis also, he had a very interesting presentation coming up, and I'm sure all of you will be impressed at his young age at what a smart, innovative idea he has. So on to you, Nilesh. Please make sure that you stay to the time.
Thank you so much, ma'am, for the kind introduction. I'll just share my screen. So I'll just start just once. Good evening, everyone. I would like to thank AIOS and BOS for providing me an opportunity to present my work, Smartphone-Based Gonio Imaging, the Present and the Future. I am Dr. Nilesh Kumar, and these are my financial disclosures. Gonioscopy is not performed as frequently as it should be. 83% of the junior residents are not at all confident performing it, and half of the patients do not get a baseline evaluation done in a glaucoma clinic. Despite being such a vital part of glaucoma diagnosis, I feel the lacunae is due to the enigma of the skill itself, its dependency on the slit lamp, the chair time it takes during a busy OPD, and lack of quality trainers. When we searched for an alternative to the gonioscopy, it was this 20 lakh machine just to take a gonio image, or a sophisticated software to do a 3D reconstruction of AIOS-SC. All of these are not viable in a resource-sensitive country like ours, the point which we raised in this letter to editor. Asking question is important, but so is finding a solution to it. We innovated a novel technique using just a 4-mirror gonio lens and a smartphone, which was validated on 65 eyes and was published in the Journal of Glaucoma. The cover art is the testament to the quality of image that we can obtain using DIGS. But as my mentor, Dr. Ashish Sharma, has told me repeatedly, no journey of an innovative idea is complete unless it is translated into a product that can be used by anyone. So we developed a frugal, one-of-its-kind device, which is now 1 year into the patent process, compatible with major type of gonio lenses and smartphones. We call it the DIGS Pro. And this is how we set up. This is the device. We place the gonio lens in the adapter, which by design aligns centrally with the optics of the smartphone holding segment, where the smartphone, be it Android or iPhone, is snap-fit. Normal camera app is to be used for clicking the image. The lens with the holder is applied in a normal fashion under topical anesthesia, and the patient is asked to look straight. The smartphone segment aligns beautifully with the lens adapter, and you just click using your camera flash. As simple as that, no slit lamp required. These are few sample images using 4-mirror lens, few sample images using 3-mirror lens. Recently, we also concluded a larger validation trial for the device, where out of 280 images, 89% were of credible quality. The kappa coefficient between the gold standard slit lamp gonioscopy and the device was 0.65, while between two masked graders was 0.82, both implying substantial agreement to classify open and closed angle. It is also a great patient education tool. Only 53% of the patient agree for YAG PI when counseled verbally. But when we show the patient their closed angle using DIGS Pro, 86% agreed for the prophylactic laser. It takes approximately 4 patients to gain this skill. Optometrists and technicians can also be trained very easily, and one thesis is underway to validate the device at community level. It can also double up as a diffuse anterior segment imaging device due to its inbuilt optics. An app is also in validation stage, which will not only make the record keeping easier, but will enable reports to be shared instantly for teleconsultation and will also give us an opportunity to collaborate for various research projects. One such project is to create a data repository using Dix-Pro images, which will then be utilized by machine learning to create an AI overlay in the app itself, so that when a technician clicks an image somewhere in the periphery, an instant notification will tell whether the patient should be referred to the hospital for further evaluation or not. That's what we imagine our future to be. So keep imagining, keep innovating, keep translating, keep digging. Thank you for your patient listening.
Thank you very much, Nilesh. Excellent once again. And
Thank you.
Just a disclaimer that yes, that is him in the photograph you saw in the PowerPoint. It's the same person. So let me quickly ask Professor George Beko for his comments and discussion for this innovation.
Thank you very much. A very nice presentation, and thank you for explaining how this process works. I think the value of your device is that it allows us to delegate the acquisition of the images to a technician, and also to be able to then show the images to the patients. And as you've aptly shown us, once you show the images to the patients are more understanding of our concerns with regard to their angle. So I congratulate you on doing that. When you say that it takes 3 or 4 attempts before somebody becomes proficient, how much time is involved with the average technician in learning this technique?
So with average technician, we had to teach them how to apply the gonio lens. That took most of the time because everybody is now well versed with taking images using a smartphone. So that is not very difficult. But to apply the gonio lens, it takes around 8 to 10 patients so that they don't get an air bubble between the application.
And how accepting are the patients of having a technician play with their eye, in essence, while they're doing this?
So in outreach camp, patients are they are very generous. They allow us. But in the setup, where in the clinical setup, it takes they are not very forgiving. So we generally use the postgraduate or the residents. They take the image in the clinical setting. The technicians are trained in the community setup, and once they are trained, when they get the skill, then they are deployed in the clinical setting. Then it is just like when they are confident enough, it's just like taking fundus images, which the technicians take.
Thank you very much. Nice presentation.
Thank you, sir.
Thank you very much, Professor Beko. I think excellent questions and very well answered, Nilesh. Can I invite Dr. Sean Anchelev to give his comment and discuss this innovation?
All right, thank you. Dr. Kumar, I would like to congratulate you 3 times. Number 1, for innovating and really trying to solve a meaningful unmet need. We have that problem all over the world. We have it in the US, from optometry to ophthalmology to residents. And we need to find a better way or cheaper way and more predictable way. So smartphone technology, I think, is coming of age where the quality of the camera is there. Somebody needs to package it and apply it. Number 2, I want to congratulate you because you're doing that as a resident. And for me, that is really close to my heart because the first 2 inventions that I introduced, which is intraocular vibrometry and virtual perimetry, I did when I was in my 2nd and 3rd degree year of residency. And I know what it takes. While you're learning in mid-flight to actually put extra work to innovate and come up with something that that is meaningful before you even know what sometimes the unmet need is as a medical or ophthalmic professional. And number 3, I thought it was a really crisp presentation. So, so thank you. Again, one of the things I would like to ask specifically to this is when you compare what you have versus doing the gonioscopy at the slit lamp, what is it that you can't get with your system? Where is the gap, if any?
The main gap what I couldn't image till now, even in the last 2 years, is neovascularization. That I have tried so many times, but the once we zoom in the pixelation, the fine vessels I can't get. That is the only one disease, that's one condition that I couldn't image till now.
Okay, yeah, and I think what one thing that came clear from your presentation, which was really fascinating to me to see that you're really thinking about it, is not just the innovation itself, but the productization. I think it seems like a lot of work has gone to productize this, make it really facile and easy to use. And also the validation. You've done almost like a reading center type validation. I don't know if the results have been published somewhere, but that's where you really prove the utility if people can grade this and you can reach acceptable level of confidence. And you're also thinking about extension of going towards machine learning and AI, because obviously there will be things that may be addressed through those aspects. So, and also, have you seen any other systems like yours in Gonio-based imaging with smartphone? And what do you think the differentiating features of yours are?
So I have come across two such systems, both from India. One is where they hold, it is from AIOS, where they hold a direct ophthalmoscope from one with the streak on and a smartphone, and then they take. But the limitation there is that you require two persons, one to throw a light from a direct ophthalmoscope and one person taking the image. And another system that has come is to fix a smartphone on the eyepiece of a slit lamp and then do a gonioscopy and take the image. The slit lamp based thing is it requires a slit lamp. Came when I saw an old lady who was not, I could not explain to her what the condition is, and then it went ahead.
Okay, well, thank you for your innovative spirit and good work. Keep it up as you move through residency.
Thank you so much.
Thank you, Dr. Enchile. I think in the interest of time, I'd like to introduce my colleague and friend, Dr. Sonu Goyal, who will be taking up the next presentation.
Thank you, Somshila. So now we have a young dynamic presenter, Dr. Parth Rana. He's a young dynamic second generation ophthalmologist, retina and ocular trauma surgeon at the Nethralaya Super Specialty Eye Hospital, Parimal Garden, Ahmedabad. And he'll be talking on the scleral tuck IOL. So all to you, Parth. The lead judges for his talk would be Dr. Boris and Professor Soonfik.
Before Parth starts his talk, Dr. Natarajan has just joined us. A quick word of welcome to you from you, Dr. Natarajan, sir.
Parth, you can just pause your video.
Natarajan, sir, are you there? I think he's logged out. Parth, please continue.
Parth, you have to unmute yourself.
Hello.
Yeah, Parth.
Yeah. Thank you so much, sir, for this opportunity. I'll be starting with my patented scleral tuck IOL. I have no financial interest whatsoever, though I have patent for this, but we have kept it open for everybody with prior consents. So I'll be talking about nucleus drop. It's horrible for everyone, right? For two main things. One is surgical and one is financial. Surgically, we have to learn so many things, so many different kind of IOLs and so many different steps to for this IOLs. And the second thing, for different kind of glue and different kind of sutures, we need so many inventory for that. So not anymore, right? Now we have this specific design of scleral tuck IOL. We call it Rana and Shah's self-sustaining scleral tuck IOL. We started designing it during my fellowship period in 2016, and we patented it in 2017. We are using it from that period. So this is basically a total new design. It's not a modification of previous generation IOL. So here, as you can see, the main difference between this IOL is this flipper. This flipper is the fixation point for this, and this neck, which tucks into the sclerotomy, which we make. And these are the 4-point fixation haptics. These haptics are quite stretchable. There's a huge optic of 6 millimeter. It can even cover a mesopic pupil in trauma or in traumatic pupil also. So this is a totally new design, and it was totally innovated from a price tag label on the clothes. So It is basically having 4 different parts, which is flipper, neck, haptic, and optic. Normal IOLs are having only haptic and optic. So here I'll be showing animated animation of the sclerotic IOL implantation. So we have to make a 3-port entry into the anterior chamber. The main port is of 3.2 millimeter clear corneal incision. We have to make 2 scleral flaps 1 millimeter away from the limbus with a 20 gauge entry below that. We can inject the IOL into the anterior chamber with the help of an injector as it is foldable. We can rotate it clockwise and we can push it below the iris with the help of a dialer, and we can just pull it out with a simple 20 gauge forceps, vitreous forceps. We don't need separate forceps, just routine ILM forceps can also work for the same. Here, as you can see, one side flipper is out and one side surgery is totally over. And the second side, we can just do the same thing with the handshake. Once we pull the flipper out and the surgery is over. And due to the flexibility of haptics and neck, it easily comes out. Either it's a these haptics are quite stretchable, so there are no issues, and it's 4-point fixation, so centration is also good. Here I am showing a real life implantation. Here I have caught the leading haptic of leading flipper. And as you can see, the leading flipper is out of the sclerotomy and one side surgery is kind of over. As you can see, I am just pulling it and the neck neck stretch quite good. And on the same other side, the same thing is repeated. As you can see, I hold the eyelet, I'm pulling it out. As you can see, the flipper is out of the sclerotomy and the surgery is almost over. And as you can see, the large optic, which is covering the total dilated pupil also. So it's a simple thing. We can just cover the scleral flaps over this and we can hood the conjunctiva. Surgery gets over within 10 to 15 minutes. No need to learn so many of the different difficult steps like suturing, glue, or making tunnels. Thank you. My presentation, so thank you.
Thank you, Parth, for that nice presentation. I would request Dr. Boris to please have his comments.
I think it's an interesting model. And my question to the author of that invention is in the ending of that haptical element that you call flipper, you have a small opening. What is the purpose for that element? Is it designed to be sutured through that opening, or it has some other meaning? So please give us the idea of the design of that flipper.
So there are 2 main reasons for that. One, we have to pull it out. So when we are trying to pull it out through neck, there are chances of chipping it out. And once it is chipped out, it's difficult to take it back through 3.2 millimeter incision. So we have made this eyelet, we are pulling it out we are holding the flipper with that eyelet. And the second thing, sometimes like in trauma, when I do surgeries, eyeball is little bit hypotonous. When eyeball is hypotonous and at that time when I want to inject it, what happens, like my MVR entry is little bit bigger than 20 gauge. So at that time, when I'm not sure, and if I want to suture it, I can suture with that eyelet. So that IOL stays there. So both the things are covered with that eyelet.
And my second question is that so we had more or less similar model that is presented having T-shaped form of the haptical element ending. Yours is a little bit more bulky, so I assume you need a little bit wider incision, so that with the wider incision, there are theoretical disadvantages of having the outflow and hypotony at the first day of postoperatively. So do you experience that?
No, sir, because the size of neck is 0.8, which is the same as 20 gauge sclerotomy. So when the neck is totally plugged there are no chances of hypotony, and within like a month or so, it gets fibrosed by itself. So there are till now we have not faced any hypotonous cases. Even in like totally vitrectomized eye trauma also we have tried, and there are no hypotonous eyes after on first day.
Thank you, Dr. Boris. I would request Professor Soonfik Ma'am, you need to unmute, ma'am.
Thank you for your presentation. This is a very interesting lens. Can I just ask, what is the material of the AIOL? Is it hydrophilic?
Yes, ma'am, it is hydrophilic, but we can make it from all the material, which is all the foldable materials, which surgeon is comfortable.
Yeah, because if you are using this in trauma, I would be rather concerned. So if you have a retina detachment later and you have to go in and you have to inject gas, or you have a cornea with a laceration that subsequently requires a graft and you have to put in air, you might occasion that hydrophilic lenses would face. So that would be a problem. The other question is regarding the incision size. I'm just wondering why you have to open a 3.2 mm incision. Can this lens be injected through a smaller corneal or limbal incision?
Definitely, ma'am. We are trying for that. But the first generation lenses which we designed and which I showed here was from 3.2 millimeter incision. But next generation, we are trying to make it a little bit smaller, and that can come out from 23 gauge, and it can come out from even 2.5 millimeter incision also. So we are under the process, and which we are going to get CE mark later on. That will be the same one which I told right now.
Okay, and the other question is, you mentioned that this is a 4-point fixation. How is it a 4-point fixation with this lens?
Ma'am, normal haptics are just there'll be a single connection to the optic, but here we have two connection to the optics, and when it is inside the eye, it is not round shape which is showed. It is of V shape because it is stretched. So it is a 4-point, and we have designed that just to minimize the pseudo-phacodonosis. And due to that, centration is always guaranteed. Once the flipper is out, centration is always there.
And how about the tilt? Does that improve the chance of tilt?
Definitely, ma'am. We have not got any chances of tilt after that because this 4-point fixation is highly stable. We have even tried after a month or something, like in some cases of trauma and all what we faced. It is kind of very stable, and due to the stretchability of material, it is quite useful even in large eye or small eye. We have not faced any of the problems.
So in cases of trauma, how is this AIOL fixation technique superior to a Yamani technique which does not require conjunctival dissection? I would imagine that you want to preserve conjunctiva because in these complicated cases, you might have glaucoma as a late complication, and you want to actually preserve the conjunctiva. In this case, you would have to open up quite a large incision in order to bring out your flipper and put it under a scleral flap. So, are there any advantages over the Yamani technique?
Ma'am, basically for all this, as I in my presentation, I told for all the IOLs which were designed before, they are just modification of the routine IOLs. So what happens in that, there are usually centration issues are there or pseudo-phacodonosis is there. But in my IOL, what is the centration comes by itself. The stretchability, like sometimes hypotonous eye is there. So in that thing, we have even an eyelet. So we can even suture it with that eyelet. If we don't have a huge scleral flap there, and if you want to suture it, suturing is also possible when we are not sure. So we have taken a multiple steps for different kind of things. Even conjunctival hooding sometimes works. Like as you told, as you asked before also, like sometimes if extrusion is there, scleral flap is little bit inside. When flipper is out of the scleral pocket, then conjunctival hooding even works. There are no issues even after conjunctival hooding. And if this extrusion is there, patients doesn't feel any of the foreign body sensation due to this material is kind of quite smooth. There are usually no issues after that. And we have follow-up of like good time, 1.5 to 2 years right now. And there are very minimal complications are there.
Thank you.
Thank you, ma'am.
Thank you, Professor Soonfik. Any other judges would like to have their comments on the presentation?
Just a quick comment. Just a quick comment.
Yeah, Professor George. Yeah, go ahead, please.
just a quick comment to both Dr. Naveen and Dr. Rana. I think our concerns as surgeons is what the pull force would be to break the haptic. So I would encourage both of you to do studies in which you apply tension and see how much force is required before the haptics fail. That would be very important for us. And also to know if the material breaks in any way. So as you go forward with your designs, please do those studies and please share that information with us.
So we have already made a presentation on that also. If we are pulling it more than 1.5 millimeter, then neck breaks. The chances of breaking haptic is minimal. And even though one haptic is breaking, it can stay on other haptic also. That also we have seen. So pulling it more than 1.5 millimeter, it's kind of difficult. Like if on starting stage, someone can do it. Otherwise, we are doing it routine right now. It's difficult if we are pulling it more than 1.5 millimeter from the scleral pocket. So usually it doesn't break that easily.
So thank you, Professor George. Thank you, Parth. So over to the next presentation. I would now request my colleague, Dr. Amit Porwal, to please take the lead.
So before Amit introduces, we'll have Professor Natarajan to give a few words. Professor Natarajan, are you there?
Yes, I'm there. Thank you, Partha. I'm audible.
Yes, sir.
Yeah. And nice to see my friends George Beko, George Rosha, then Chen Fonsek. Hi, Chen Fonsek and Gopal, and I think I welcome all of you and all my friends here. And sorry, I got I'm in Chennai actually with my mentor. So I just took some time to log in. Thank you, and I wish you all the best, and wish all the participants. And I think as part of the tour of the talent search. So I think I hope our international friends appreciate our young talents. And I think I learned a lot in the last so many episodes. And I wish our seniors, the way they are questioning, I think I want the youngsters to take it constructively and also happily, so that like the previous comments were that you should do a study. I think definitely both the candidates should do Parth and Nivian. And I think I should congratulate our chairman scientific committee, Partha, and President Maipal and Namrata and all the scientific committee members for a wonderful show. So all the best. And Amit, take over.
Yeah, thank you, Dr. Natarajan. So it's my pleasure to introduce our next young Turk, Dr. Rohit Modi. He is a consultant in Gokuldam Medical Center in Goregaon, East Mumbai, also in Anand Nursing Home and Healthcare in Borivali, East Mumbai, and Centra Clinic and Hospital in Malad, East Mumbai. He is a person with a lot of jugards. Jugards is basically different version of talent. So he's going to talk on various jugards, ACA Medical Hackathon. So over to you, Dr. Rohit. And the lead judges for Dr. Rohit is Dr. Sean Yanchulev and Dr. Kelvin Chong. So Rohit, all yours.
Thank you, sir, for the introduction.
Keep a track on the time. Yeah, Rohit, start sharing the screen.
Yeah. Is my screen visible right now?
Yeah, screen is visible, Rohit.
Okay, I will start now. Good evening. I'm going to present on Jugadathon, aka Medical Hackathon. At the onset, I would like to thank AIOS and MOS for giving me the opportunity to conduct the Medical Hackathon during their annual conference. My alma mater, LV Prasad Eye Institute, for the inspiration, Makers Asylum Mumbai, the fabrication lab, my teammates, patients, and family. Jugaad means hack in to make life simpler. In India, we are known for making cost-effective hacks. Now let's imagine how can we extrapolate this to ophthalmology. Often when we are working in outpatient clinics and in an operating room, we get an eureka moment or an idea to make our surgery simpler, to design cost-effective instruments. But we are unable to execute it because of lack of technical support. Hackathon gives an opportunity to an ophthalmologist to become an innovator. Around 6 years back, when I was setting up my first clinic, I was faced with a similar challenge of anterior segment photography. At that time, a lot of people were publishing their own smartphone adapters, which were designed for a particular kind of a smartphone and a slit lamp make. I wanted a universal one. Hence, I approached Makers Asylum, formed a team with a biomedical engineer and a product designer. And a similar concept can be extrapolated to ophthalmology conferences, where different teams can work for a few days, come up with a working prototype, and the best prototype gets a sponsorship to develop the product. And hence the global slit lamp adapter was made, which is universal in nature. It got a patent design in India and it is being sold online. These are the results. Another inspiration was from Dr. Mukesh Dholakia. He's a fellow ophthalmologist. He made a smartphone attachment for a fundus camera, and it was made of PVC pipe. Now the challenge with PVC pipe is to lathe cut it and design it. It is difficult for an average ophthalmologist. We teamed up with Lavina Uttamani, who's a biomedical engineer, and redesigned it using a 3D printer. And this can be made easily available for less than $20. Your own fundus camera. Another challenge was a smart angle imaging device. This challenge was taken up during the annual Maharashtra Ophthalmic Society's hackathon, where we had fixated the gonio mirror with a convex lens over to the smartphone, and the results were demonstrated on a demo eye model. Now let's look at another challenge, is of the intravitreal injection. A lot of these intravitreal injections are routinely given by all segments, all surgeons, and there have been complications reported. We were inspired by this design which we saw online, and this design was replicated during the annual Maharashtra Ophthalmic Society's conference, and this was also done to promote rapid prototyping and to demonstrate it in front of fellow ophthalmologists using 3D printing. Compliance is always an issue in amblyopia. Here we have created, using the light-dependent sensor model, the smartphone-linked time tracker for amblyopia occlusion therapy. Here we can actually know the exact compliance by the kids using an app. In conclusion, we can come up with cost-effective solutions. It gives an impetus to research. Everybody wants to be an innovator. Hackathon makes innovation accessible and a reality for postgraduates, private practitioners, and creates a culture where if you have an idea, you can make it a reality. Thank you. We got this published in Kerala Journal of Ophthalmology.
Great, Rohit. So we have our lead judges, Dr. Yanchulev and Dr. Kevin Chong for you. So we would open up the discussion with Dr. Sean Yanchulev. Sean, all yours.
Thank you. Again, a wonderful presentation, Dr. Modi. I'm glad that presentation like that is part of this program, because one of the things we immediately default when we think about innovation is devices and specific products. In some cases, very helpful widgets. But one of the things we often ignore are service and process innovations. And there is a lot about that actually doesn't get credit in India in particular. When I go and see how many patients are being treated very efficiently, something that we cannot do here in the United States as well. So I think this illustrates the concept of service/process innovation, of how you can more collaboratively, efficiently get the process of innovation jump-started. Can you tell us a little bit more about how big is that hackathon? Who are the stakeholders? Who do you bring at the table, and how do you bring those people? Because I think that is part of the secret sauce in terms of getting the right people, the right minds to participate in this mind share.
Thank you for your question, Dr. Sean. I was inspired by the idea of hackathon from my alma mater, from LB Prasad Eye Institute. They have a Engineering the Eye yearly program in July. And what we have done during the MOS and the AIOS hackathon was, we invited engineers which were already a part of the ophthalmic industry working for different companies. Also, back in Mumbai, I have got the luxury of having multiple fabrication labs. So we had invited engineers from Mumbai. And then we had also, by sending emails, invited ideas. And based on that, we had formed teams and we had decided to pursue a few ideas, and we had decided to also gather the hardware beforehand. So this way, both the hackathons were conducted, one in Maharashtra Ophthalmic Society and other for the All India for a couple of days. And these products which were showcased were made, these prototypes were made during those hackathons.
Okay, and that's fair. And one of the things that I found really prevents this collaborative exchange or shared exchange of ideas and development is intellectual property. As you know, a lot of us inventors really feel very strongly about our ideas, and people that I see out there, particularly the ones that are in the clinical trenches all the time, if they have great ideas, they're so afraid to share them. And if you don't share them or you don't pressure test them, it's very hard to actually develop them. So how do you handle the problem of intellectual property in those early stages? And how do you break down that barrier if people simply don't want to come to the hackathon or share their idea because they're afraid somebody will steal it?
I agree. It's still at a nascent stage. When we talk about intellectual property in terms of product development, but the idea is that the best team, basically, which gets a sponsorship from the industry and the society and the industry also are a part of the royalty process if a product is maintained, and the team which wins also gets a share in the loyalty. And that can be decided upon the product cost and the reach of the product. And the industry sponsor, the one who sponsors the hackathon, gets the first shot at manufacturing the product.
Okay. And I assume your priorities are mostly for the Indian market, or do you look beyond as well?
We can definitely look beyond it. The first two hackathons which were conducted, my main target was to encourage research and wanted to showcase that research can be done by individual private practitioners also. So if you have an idea, there are a lot of fabrication labs which are coming up even in 2 and 3 tier cities, smaller towns in India. And Dr. Mukesh Dholakia, who's one of my inspiration, is working in a quite remote location in India. And then he goes to these these machining tool industries where they do not have any idea, but he comes up with unique designs. So my idea of hackathon was to promote research and just to showcase that any one of us can do research and come up with beautiful products.
Oh, great. Congratulations on starting that. I think it's great. It's in the ideation phases still. Hopefully you can practicalize it and make it a real solution that can produce a lot more products in the future, because those products for the global ophthalmic innovation are really needed. We don't need the most sophisticated phaco machine that we can use here in New York in order to treat cataract blindness in Africa or somewhere else. So there is a different type of innovation need out there that can really be addressed by a service platform that you described.
Thank you, sir, for your kind words.
Thank you, Sean.
Partha, can I make a comment?
So yes, a quick one, sir.
Yeah, no, I think saying excellent comments, and I think you are in New York and you should get some stock exchange from New York to sponsor them, because I think the problem in India is we have great ideas, but we don't have supporters like from I think Ratan Tata supports. He's a great supporter of innovators. He runs the Jaguar company. But the problem is he's not supporting small people like Rohit. I mean, he's done a great job, and all these people what he have done. I think we have a lot of billionaires in India, but they're not investing in these sort of small startups. And I think in US, you have a lot of startups who can be supported by some great stock exchange people.
I agree. And you know, I'm from Bulgaria when I came to the United States, and there are brilliant people there all over the world. I think one of the differentiation here is that we have a lot more access to venture capital.
Yes.
So when you need to go to the next stage beyond the ideation, more into the productization, that's where you need it. It's kind of the octane and the oxygen at the same time. But I've seen amazing shoestring innovation in India. So even without it, and hopefully there'll be more venture capital. And I'm always available with Venkatesh. We talk all the time how we can collaborate on projects. So hopefully something will come out of that.
I know Mark Humayun and even our Dijuan has got their own companies, but I think they have backed by venture capitalists. And the guy in Rutgers University, Marco Zarbin, his classmates his classmates, I think I forgot the two names he told me when I asked for research in RP transplant. He said there are ophthalmologists who have gone into venture capitalism. So probably if you can, I think introduce Partha to have a webinar with them and see whether the winners of this can be a part of that, and they see the idea, maybe they can invest. And just
Thank you, Natarajan. Thank you, Dr. Natarajan. So we take a comment from Dr. Kelvin Chong. Your questions to Dr. Rohit.
Thank you very much. And I think I have to congratulate Modi for a very good platform presentation. I also use 3D printing in my oculoplastic practice. So I have a few questions for you. What types of 3D printer are you using for each of these devices? And roughly, do you have any idea the costs for printing any of these adapters?
Yeah, thank you for your question. So Dr. Kelvin, we are using a very basic type of 3D printers which are routinely available at the fabrication labs. The 3D printing process is taken care by the product designer, and the cost of production of the slit lamp adapter was less than 1,000 rupees, in fact, which is roughly around $15 to $20 in India. And the cost of, again, 3D printing the fundus camera attachment was less than $20. So in Mumbai, the 3D printing is quite inexpensive, and the basic 3D printing.
Again, a follow-up question that some of the judges asked in prior projects. And are you planning to use these adapters for non-ophthalmologists, allied healthcare that can help to bring the service to a more community level, or you plan for these adapters to be used by ophthalmologists?
So the fundus camera attachment is already used by the paramedics like the optometrist, and they're quite comfortable with that, as has been shown by Dr. John in his presentation. The concept is quite similar. The paramedics can use, and the slit lamp adapter is pretty simple. Once you attach it to the slit lamp, anybody with a basic, even the vision technicians can use that. For those two instruments, we are pretty comfortable that they're going to be used by paramedics as well.
I think a final comment is if you have any ways for users to have feedbacks, because 3D printing is something that is quite rigid itself as additive manufacturing. So if you have ways that the end users can feedback in terms of size and shapes and forms, that would be perfect.
Yeah, sir. Yeah. Thank you for that comment. I just wanted to add the second version of adapter was made in the metal so that we can have adjustable screws over here, so that the size of the eyepiece doesn't matter. You can fit it to any kind of eyepiece. That's what made the second version of global slit lamp adapter universal. Thank you for your suggestion.
Thank you, Rohit. Thank you, Dr. Kelvin and Dr. Yantulev. So we have finished. We have come 50%. We have finished half. We are in halfway. We have finished 50% of our Young Turks presentations, and now we have crossed 1 hour 45 minutes. So just to remind all our judges, all our moderators, and all our chairpersons, we are running late. So we just stick to the questions from the judges so that the Young Turks are evaluated properly. And now I invite Dr. Feiruz, our scientific committee member, to introduce our next speaker, Dr. Samendra Karkur. Over to you, Feiruz.
Thank you, Dr. Ahmed. So we have the next young and vibrant speaker, Dr. Samendra Karkur, who's the assistant professor at the Department of Ophthalmology, All India Institute of Medical Science in Bhopal, which is a center part of India. And he has been excellent in academics so far as a postgraduate student, resident, to a consultant at this point of time. And we are waiting for your fantastic presentation, Dr. Karkur. Over to you and all the very best.
Thank you so much, Dr. Feiruz, for that introduction. It's a great privilege to be presenting here before you all international panel. I'm sharing my screen.
A 32-year-old male presented with bilateral diminution of vision for last 10 years. In the right eye, the vision was light perception 8 on 10, and in the left eye was light perception with accurate projection of rays. Based on the ultrasound and UBM findings, we decided to operate the left eye since right eye was inoperable. Corneal dimensions were measured using calipers in order to decide the size of host button. Corneal center was marked and host button was cut out using trephine. Deep anterior stromal dissection was carried out using crescent knife and blunt dissection. Host button was removed, leaving behind Descemet's membrane and a thin film of stroma. Visualization of the anterior chamber details was possible, hence sclerostomy ports were made and vitrectomy was started. After completion of core vitrectomy, due to the hard nature of the dropped nucleus, decision to use phaco-fragmentation was taken. Localized peritomy was performed and 20-gauge MVR knife was used to make fourth port for phaco-fragmentation probe. Phaco-fragmentation was started due to the scarring of deep residual corneal stroma and non-dilating pupil. The view was limited throughout the procedure. After completion of the phaco-fragmentation of the nucleus, the fourth port was closed using vicryl sutures. Residual vitrectomy was completed with base dissection and peripheral fundus examination was performed. Remaining vitrectomy ports were removed and closed using vicryl sutures. Host surface was washed and donor button was placed. After placement of the cardinal sutures, the donor button was secured using interrupted sutures. Post-operative period was uneventful and best corrected visual acuity at 1 month was counting fingers at 3 meters. On slit lamp examination, graft button and graft host interface was clear, sutures were healthy and AC was well formed.
This procedure helped us to avoid the keratoprosthesis, which involves an extra step. Thank you very much.
Thank you so much, Dr. Karkur, for an excellent presentation and the video. So we have the lead judges today for this presentation, Dr. Lingam Gopal and Professor Elmo too. May I request Dr. Lingam Gopal to initiate the discussion? Over to you, sir.
Yeah, I think it was a good presentation of a combination of anti-segment and posterior segment surgery. The only question I have is, what was the need for the fourth port? In the sense, you could have enlarged one of the ports, which is already there, and since a 25 gauge, when you remove the trocar, it becomes almost like a 23 gauge, and enlarging it to 20 gauge, you can still place back the trocar and continue with your surgery without worrying about leakage. It won't pop out that easily. So I don't think there was a need for making a fourth port. That's the only point I have to make.
So we do hybrid surgeries most of the times. But in this case, I felt that because we were using phacofragmatome, which causes a lot of fluidic disturbance in the vitreous cavity. So we thought that it would be prudent to actually use that port, suture it close, and then go ahead with her previous vitrectomy. Otherwise, we would have to use a mattress sealing suture after a 20 gauge port if we were to go back to a 25 gauge or a 23 gauge port in the same incision. So that was the only thing, but I agree with you. Yes.
Thank you. Professor Tu, may I invite you for the discussion of this case? Over to you.
Thank you. A couple of questions. What viewing system did you use for the posterior segment? Did you have to put a contact lens over this, or did you use a biome?
Dr. Chu, this visualization through this non-dilating pupil and scarred stroma was only possible through the ReSight viewing system, which we use with the Lumera microscope.
Okay.
Non-contact.
And then, I guess the decision to do a DALC in this particular case, was there concern that the endothelium was functional or non-functional, or some supposition of that?
The decision to do DALC was actually an on-table decision. We were ready with a full thickness penetrating keratoplasty, but the only thing was that we wanted to avoid as many surgical steps as possible, because this was practically a one-eyed patient, and we felt that if we do a full thickness penetrating keratoplasty, it would lead to higher chances of graft rejection, and we wanted to give it a chance to go ahead with lamellar keratoplasty. Had it failed, we would have gone ahead with the full thickness keratoplasty. And it also avoided the use of keratoprosthesis in the process.
I mean, it's turned out beautifully. You did a wonderful job. Are there any other procedures at this point that the patient might find beneficial for their vision? Is the corneal clarity now a limiting factor, or is there some other limiting factor for the patient?
The fundus examination was fine. We did not find any problem with the disc or macula, or for that matter, the posterior pole. The only problem was with the cornea, and the best we could achieve was doing as much dissection of the deep dissection of the stroma as possible and placing a good graft. But because the patient is aphakic, and of course we are definitely, and he does not improve on best correction also, so we feel that probably there is some deep scarring, which is a limiting factor in vision in this patient.
Congratulations, beautiful surgery.
Thank you.
Thank you, Professor Tu. So we can take a very quick comment or questions from other judges, if at all we have few. All right, so we go on to the next speaker of the day, and may I request Dr. Balla to introduce the next speaker. Over to you, Dr. Balla. Dr. Balla?
Yeah. Now hello. Hello. Yeah. Dr. Saurabh Kamal is the next participant. He's working as consultant ophthalmic plastic surgeon at iHub in Faridabad, besides working as oculoplastic surgeon at I7 Chaudhary Eye Center and MM Tech New Delhi, and also at Mishri Devi Eye Hospital in Neemrana and Behror, Rajasthan. He's a renowned oculoplastic surgeon in Delhi and NCR region. And the lead judges for Dr. Saurabh Kamal's presentation are Dr. Kelvin Chong, Professor Geoffrey Rose, and Dr. Presentation. And all the best.
Thank you, Dr. Balla, for introducing me. I'm sharing my screen. Is my slide visible?
Yes, and audible, Dr. Saurabh.
Thank you. So my topic is intranasal cyst in congenital nasolacrimal duct obstruction. With the use of nasal endoscopy and case-based approach in CNLDO has caused the paradigm shift in the management of CNLDO. This has led to the recognition of these rare intranasal cysts, which are seen primarily in congenital dacryocele. Now, these cysts occur because of the increased pressure within the dacryocele, which is transmitted to the lower NLD, causing the formation of intranasal cyst. These large intranasal cysts can cause respiratory insufficiency, recurrence, and acute dacryocystitis, and therefore their treatment in form of cruciate marsupialization has been well documented in literature. However, there are children with intranasal cysts which don't have any dacryocele, can have intranasal cysts. These occur because of the anatomical malformation at the lower NLD. So the purpose of this study is to describe the clinical features, types, and management outcomes of CNLDO. It was a retrospective case series by a single surgeon. All children underwent nasal endoscopic guided probing under general anesthesia. Anatomically, the cysts were classified as small if they were completely hidden beneath the inferior turbinate and required its middleization, whereas a large intranasal cyst could be seen without the use of middleization. All cysts underwent cruciate marsupialization. Only cases with minimal follow-up of 3 months were included in study. Over 4 years period, 33 patients with 34 included. Incidence of cyst was 12.4%. The mean age was 18.7 months. There was a one bilateral case. Acute dacryocystitis was noted in 6% of the cases. There was history of probing once in 41% and twice in 15%. 6 cases had dacryocele. On anatomical classification, small cysts accounted for 74%, and on clinical classification, the simple and the complex were seen in almost equal proportion. Complex, based on clinical findings, were further divided into fibrotic, abscess, multicystic, and loculations, thick wall. Atonicity was seen in 41%. On further subgroup analysis, all children without dacryocele had small intranasal cyst. All children with dacryocele had large intranasal cyst. Within the simple type, small accounted for 61%, and within the complex type, small accounted for majority, that is 87% of the cases. Now coming on to the resolution was delayed because of the SAC atonicity, and success rate was noticed in 94% of the cases. On nasal endoscopy, this small simple cyst can be noted on middleization of inferior turbinate, is undergoing cruciate marsupialization with 2 perpendicular incisions and 45-degree probe tilt test to ensure the complete opening, followed by fluorescent stained irrigation. This child having acute dacryocystitis was noted to have small white to yellowish intranasal cyst, and therefore underwent drainage and administration of systemic intravenous antibiotics. In this case, after cruciate marsupialization was done, thick mucus was seen over probe, and on 45-degree probe test with back and forth movement, further drainage of the pus can be seen, suggesting multiple loculations within the cyst. This was a case of a flat, small fibrotic cyst, which can be difficult to appreciate and missed endoscopically, is undergoing cruciate marsupialization and 45-degree probe test with fluorescent stained irrigation. To conclude, intranasal cyst can be seen in CNLDO with or without dacryocele. This is the first study to propose the classification of these cysts with the clinico-pathologic correlation. We believe that this classification, along with the key factors in management as discussed, will lead to the better understanding of this rare and intriguing disorder with higher eventual outcome. Thank you.
I would invite the lead judges for the case, Dr. Kelvin Chong, for his comments.
Thank you very much for the very interesting talk. And I'm trying to ask a basic question. Do you suggest that after your study that the congenital NLDO or probing should be done under endoscopic guidance in the first place?
Thank you, Dr. Kelvin. Yes, the gold standard now obviously is the endoscopic guided probing in any children. If you are not the first initial attempt, obviously we know for second and failure cases, but it should be there with the first attempt itself. The nasal endoscopy should be and must be performed at the primary treatment point of view.
And the follow-up question, just before we finish, is after the cruciate incision, would you consider taking out all the cyst remnants for histology and to improve the outcome?
Yes, that can be done for definitely for the large cyst. Some part of the cyst can be removed. Those are seen usually with the dacryocyl. With a smaller cyst, there may be difficulty in getting, the pathological specimen. And basically, that could be, my further point to look, to consider, to specify these and look the pathological findings in the cyst wall itself, and to correlate with the clinical condition of the child.
Thank you very much.
Professor Rose, please, sir.
Thank you. Thank you very much, Saurabh, for the talk, which was interesting. Do you think small cysts are normal? They're just the dilated lower end of the nasolacrimal duct? Because you have a very selected group of patients.
Yes. If you look into the previous literature, there has been a description of what is called the NLD outpouching, or the redundant mucosa in the few literature in the 2004. When they were initially not described as a small, only those were described like which were having associated with dacryocyl. Those were usually large cysts. Now the population which I have studied, these are very small cysts, and most of them they didn't have any dacryocyl. So what I propose that first is there the description of the cyst, whether how the cyst is and the patient are clinically, and second, they should undergo cruciate marsupialization, because that is a cystic cavity and it has to be opened adequately, completely, to ensure the opening of NLD. So earlier what was described was just the marsupialization, or the removal of the entire wall of the cyst.
Yeah, because your series actually has quite a high rate of congenital fistulae, agenesis of the upper canaliculi. So I think you probably got a pretty abnormal group, and also they're a group with failed probings. So there is an interesting observation and some very good pictures, but you may have selected the abnormal end of the spectrum. But thank you very much.
Thank you, Dr. Rose.
Now you'd invite the next lead judge for the presentation, Dr. Sean Ianchulev. Dr. Sean, please.
Thank you. I think that this is a very fascinating study. I like the analytical part. I agree with the prior comment that it seems like there is a little bit of selection bias here for this observational or retrospective study, which is pretty common. But at the same time, it really highlights the aspect whereby I think the new endoscopic techniques and nasoendoscopic techniques are really helpful in uncovering new pathology. Do you think that some of the paradigm now has to change, and how would you change it based on this observation? And also, given that this may be suffering from a little bit of selection bias, how would you go forward in terms of validating this cohort that you have further to see if that applies beyond your population?
Thank you, Dr. Sean. Good questions. First of all, obviously the selection bias will be there, because as you see in my criteria, most of the children, most of the patients, they were having a failed probing, almost 50%, more than 50%. So this is because of my referral practice, because I'm primarily doing endoscopic work on the CNLDO. So I do get a lot of failed cases, and therefore it may be having noticed the incidence of intranasal cysts to around like 12% in my series. Now, to further look into the findings of the analysis and the description of the various variant of the cyst. Now, this will be is very important, because as seen in some of the cases, if the thick wall is thick, or the cyst have some abnormal loculations, or any of the abscess, those will need some further steps along with the cruciate marsupialization, so as to achieve a high and good success outcome. So to have these children, get treated with the nasal endoscopy guided probing will become obviously the gold standard, and in such cases the anatomical findings may be described and further studied also. So as Dr. Kelvin said, pathologically,
perfect.
all can be studied.
So I have a bit of a loaded question for you. I totally understand the very astute clinical observation here you've made. How would you take that further into the field of innovation? How would you innovate beyond your observation?
This is the first step, like for the description of the intranasal cyst. The next will be, to have, obviously, those people who are not doing, they should do nasal endoscopy, must do in a case of CNLO at the primary treatment itself. And if they see the intranasal cyst anyway, so those should be managed accordingly. So the primary message is like the intranasal abnormalities. There are many apart from the intranasal cyst. This is the one group which I described. So there will be many other abnormalities also apart from intranasal cyst. So nasal endoscopy must be done in all the cases. So that is my primary message. Thank you.
Thank you.
So,
good work.
Yeah. Any other quick comment or question from any other judges? So Dr. Saurabh Kamal has shown that the astute observation may really unearth a new pathology. Now, I would invite my close friend, the Dynamic Scientific Committee member, Dr. Krishna Prasad Kudlu, to take over from here and introduce Dr. Shail Vasavda.
Dr. Kudlu is unable to log in. So yeah. I have the great privilege of introducing Shail, a very young, dynamic surgeon, very confident, senior consultant at Raghudeep Eye Hospital at Ahmedabad. Over to you, Shail.
Thank you. Thank you very much, sir. I'll be discussing long-term outcomes of toric IOL implantation in children undergoing cataract surgery. The overall incidence of astigmatism in children is reported to be variable from 2% to 34%. Very limited studies in children post-operatively have shown that astigmatism in pediatric population after cataract surgeries ranges from 1 to 3.5 diopters on an average. And it's been shown that amblyopia, amongst all the other causes, the astigmatism is supposed to cause the highest amount of amblyopia amongst all the refractive errors. Literature does give evidence that the corneal curvature stabilizes around 3 to 5 years of age. So after around 3, 4, 5 years of age, the change in the keratometry doesn't occur very significantly. The next shift in the corneal astigmatism occurs only after 50 years of age or after adulthood. So we decided to evaluate the visual outcomes following toric IOL implantation in children with significant astigmatism undergoing cataract surgery. It was a prospective interventional series, 76 eyes of 51 children, which means we included both unilateral as well as bilateral cataracts, with the minimum age of 5 years to the maximum age of 15 years. And the main criteria for including the patients was to their ability to cooperate for corneal examination and good readings. So all patients were evaluated by keratometry, biometry, and particularly topography. The IOL calculation was done by the SRK2T formula, and the toric IOL that was used was the Acrisoft toric calculator using the Holiday algorithm. As the study was started in 2015. We did a planned manual posterior capsulorhexis in all children less than 10 years of age, and the aim was not to do vitrectomy in any of them since they were older children. And we had a follow-up protocol starting from 1 day up to 3 years of follow-up. So all patients had 3 years of follow-up. The outcome measures were the uncorrected and the corrected distance visual acuity. More important was the rotational stability of toric IOL and how it performs over the period of several years. And the rotational stability was studied by our own previously described method in literature, a software-based assessment based on photoslit images captured using an Adobe Photoshop modified software. So 61 eyes did underwent PCCC, and in 15 eyes intraoperatively it was felt not necessary to undergo PCCC as they were older than 10 years of age. In 8 eyes, vitreous was disturbed during posterior capsulorhexis, and therefore pars plana vitrectomy was performed. Coming to the results, the preoperative uncorrected visual acuity improved significantly post-operatively and which sustained at 3 years post-operatively. And even the corrected distance visual acuity at 3 years was significantly better. 5 eyes of 5 patients with unilateral cataract did not improve, most likely due to amblyopia. And 4 eyes required YAG capsulotomy. And the mean astigmatism at 3 years remained stable. 92% were within 1 diopter, and rotationally, there was no difference between the PCCC and the no PCCC group. These are representative images. Dr. Jagatram and his group have shown the role of toric IOLs in children with less than 1 year of follow-up and in 10 to 12 eyes. So ours is probably the largest series of toric IOLs in children with the longest follow-up and with objective rotational stability in pediatric patients. And we feel it's going to be a useful change in paradigm in older children treating with the corneal astigmatism. Thank you so much.
Thank you very much, Shell. Our lead judges for you, Professor Chisun Fek and Dr. George Biko.
Thank you, Shail, for a very nice presentation on a large series of children. Can I ask why you chose to use the SRKT formula when there are others that are available today that have been shown to be perhaps more accurate?
Absolutely. I think that's a very valid question, at least as of now. So 2 things. First, this is a pediatric age group. So all of the newer formulas, including the Barrett's, which we use as a rule now for most eyes, have not been validated for the pediatric eyes. So we have validated the SRKT in our previous studies to work well in our hands. Also, this study was started in 2015 because we had a minimum 3-year post-operative follow-up. So at that point of time, still they were, we weren't sure how the Barrett's would be working in a pediatric population as we did not have enough experience. We are actually working on another study now validating the Barrett's algorithm also in pediatric population. So hopefully we'll find out soon.
It's challenging to deal with children, especially if they know they're facing surgery and general anesthesia. Can you tell us how you managed to place your reference marks on the patient's eye, or did you do this with the buccal system?
No, so this was done most of the children who have probably cooperated for a good topography reading usually allow at least one good marking to be done. So typically we would our aim and we could manage in almost all patients to do it pre-operatively outside before inducing them under general anesthesia, because once they are induced there can be tilt of the eye a little bit or cyclorotation which may make it difficult. So it was just coaxing the children and letting them allow us to make a mark or so.
So with the eyes that you had done a PCCC, was there a particular size that you wanted to limit it to? Because by removing the posterior capsule, would that kind of allow easier rotation of the IOL?
So that was one of the major concerns that we had when we started the study. So as these were older children, our aim was not to make a very large posterior capsular axis, because the aim was not to capture the IOL. The aim was just to make sure that the central visual axis remains clear. To be honest, we didn't actually mark it on the cornea and try and follow a specific measurement, but usually I would say somewhere between 3.2 millimeters we would try to limit it to that, not very large.
Do you think you would have done a posterior optic capture in these eyes, thinking about the study again? Do you think that would improve the stabilization?
Because these are single piece IOL. So I think that would probably not work with the single piece design. I think if companies come up with 3-piece toric IOL designs, that would be a wonderful thing to make sure that this IOL never rotates. But I think with the single piece, it will be difficult to do that.
Yeah, so my last question to you is with regard to the single piece IOL that you chose to use. Are you concerned about glistenings? Because these are very young children and it's going to stay in the eye for many, many years to come. And we know that the lens platform that you use actually is associated with glistenings over time.
Very true, very true. I think we don't have a very good answer to that, to be honest. I don't have a good answer. Our experience over so many years has been not, very disappointing that in the sense the glistenings we do not find affect the outcome very much. But you're correct. That's a very valid concern, and I echo that. Yeah.
Thank you.
So, Jay, thank you very much for asking that question. That was top of my mind, as you can imagine. But I'll ask a different question. I congratulate you for this long-term follow-up. Most of our studies on toric IOLs have follow-up of 6 months, and we look at stability that way. Did you see any change in the rotational stability beyond 6 months? You have follow-up up to 3 years. Did you see anything that was different from before in terms of that extended follow-up?
Yeah, so in adults, what we found in our previous studies was that beyond 6 months, there was hardly any rotation. In children, we, to be honest, expected little more change over a period of time. What we did find was, to be honest, no clinically significant rotation. So there was about 1.2 degrees rotation over 6 months to 3 years in the no PCCC group, and in the PCCC group it was about 2.2 or 2.3. So there was no clinically statistical difference even after 6 months, which is a good sign that even for pediatric follow-ups, maybe a follow-up of say a year or so should be sufficient to say that this IOL is stable now.
The other question is, when you target the amount of toric correction that you're doing, do you adjust that at all for the pediatric group? What is your target?
So no, we generally for the astigmatism part, we do not change or try to undercorrect or overcorrect. For the spherical part, we do have our own unpublished nomogram, but most of these children were more than 5 years. So up to about say 5 to 8 years, we undercorrect them by about 5 to 7%. Beyond that, we do not undercorrect them even for the spherical equivalent. But for the astigmatism part, we do not change anything. Whatever the calculator would suggest, we would follow that.
Thank you very much.
Thank you very much. And we move over to our next participant.
I would like to introduce Dr. Shweta Gupta. Dr. Shweta Gupta has done her MBBS and MS from the prestigious PGI Chandigarh, and she is a fellow of ophthalmic plastic surgery, orbit, and oculo-oncology from the LV Prasad Eye Institute. At present, she is the Chief Medical Administrator and a consultant oculoplastic surgeon, Shankara Eye Foundation Indore Unit. So she juggles both administration and surgery. And this time she is speaking on DCR simulation, probability to reality. I mean, we have so much on simulation for cataract surgery, for vitrectomies, but it's the first time she's done something for DCR. And for her, we have lead judges, Dr. Kevin Chong, Professor Geoffrey Rose, and Professor Elmer Tu. Over to you, Dr. Shweta Gupta.
Thank you so much, sir, for the kind introduction. So I'm going to share my screen. So good evening, everyone. I'm going to speak about DCR simulation. So the current options for the DCR training are hands-on training and cadaver dissection courses. Hands-on training is the ideal way to learn. However, there are certain barriers to it, such as variation in the surgical exposure and opportunities, enigma of the surgery, ethical concerns, and impact of COVID-19. The best alternative available is the cadaver dissection course. However, it is not feasible always due to high cost, limited availability, and difficult access. So in surgical training, it is very important to start off right, and thus the simulation-based training is the way to go. So similar to other surgery simulation models, there is nothing available till now for the DCR surgery. And here I'm going to demonstrate a prototype simulation model for the DCR surgery, which is first of its kind. It is low cost and easy to assemble. So let's see how it is designed. So a white plastic mask mimicking the skull is taken and the osteotomy site is marked. A balloon is used to create the nasal mucosa. And at the mark site, it is secured on the inner part of the skull. The micropore tape is used to simulate the orbital septum. The carbon plus capsules, which mimics the lacrimal sac, is used and placed at the desired location. So this model helps the trainees to practice majority of the DCR steps. Now let us go through the DCR steps using this model. So this is the assembled design of the model. So after palpating the anterior lacrimal crest, a curvilinear incision along 12 mm is made. The blunt orbicularis dissection is carried out to reach the periosteum. A cat's-paw retractor is placed. The lacrimal sac is retracted laterally and the periosteum is exposed. An incision is given in the periosteum, and with the help of Freer's elevator, the periosteum is lifted up and the lacrimal fossa is exposed. The lacrimal bone is now punctured and the osteotomy is started. With the help of Carrison Rounger, which is inserted gently between the bone and the nasal mucosa, and the osteotomy enlarged, exposing the pinkish nasal mucosa. The extent of the osteotomy is ensured in all the directions. Now the lacrimal sac flaps are created. Using a 15-number blade, a vertical incision is made from the fundus of the sac to the nasolacrimal duct. This vertical incision is now converted into an H-shaped incision with the help of conjunctival scissors.
1 minute left.
Making a large anterior flap, and the posterior flaps are trimmed out. Similarly, with the help of conjunctival scissors or 15-number blade, the nasal mucosal flaps are created, making a large anterior flaps. Now, corresponding anterior flaps of the nasal mucosa and the lacrimal sac are secured with an end-to-end apposition using a 6-0 vicryl suture. 3 such sutures are passed to maintain the anastomosis. At the end, a layered closure of orbicularis and skin is done. So this simulation model will definitely help in surgical training of DCR by filling all the gaps. And I will end my presentation with the quote by Edison that if there is a way to do it better, find it. Thank you so much. Thank you so much for the opportunity.
Thank you, Dr. Shweta. You just overshot by a few seconds, but it was a very innovative technique. I would request Dr. Kelvin Chong to make his comments.
Thank you very much, Dr. Gupta, for this very interesting model. I have some question in mind. Which part of the DCR steps do you think is most critical for beginners?
So I think for me, and as far as I have assisted and like observed few of my junior colleagues, I have observed that making the lacrimal sac flaps is the toughest part of the DCR surgery, where they make a partial thickness incision, or they will make a incision in the posterior part behind the lacrimal sac. So I find that is the most difficult part.
Thank you, Dr. Gupta. The reason why I asked this in the first place is I think your model is very good for that particular purpose, incision, creating the flaps and suturing them. But when I taught, I seldom do external DCR. Most of them were done endoscopically. Most of my fellows find osteotomy to be the most challenging part, especially the extreme, the superior or the inferior part of the extent of the vertical osteotomy. So I think the model itself has this virtue, but you probably want to have a version 2 of this, focusing also on the osteotomy part.
Yes,
Thank
sir.
you.
Yes, sure, Dr. John.
Thank you. Professor Geoffrey Rose.
Thank you very much, Shweta, for an interesting talk. And I won't look at oil capsules the same way again. But do you think it's worthwhile getting your residents to actually try suturing the back flaps, because one of the hardest things is suturing down a hole. And if you can get them doing that skill, either by putting a ring on the outside of it to make it a bit of a deeper hole in which they work, it would hone their skills once they're getting good at it. But overall, it's nice. And the other thing is get a bit of blood.
Dr. Jose, thank you so much for the question. So as far as the literature is concerned, they have not shown any extra advantage of suturing the posterior flaps. So the suturing only anterior flaps gives the same success rates in comparison to suturing both the flaps. But obviously, if the surgeon's choice is to suture the posterior flaps as well, then with this model, we can ask the trainees to practice that as well. So.
Yes, I think it's like playing the piano. The more difficult the piece you do, the better you get at playing the piano in general. So I would make them do it and also make it a deeper hole probably. But thank you very much.
Yes, thank you. I agree. Thank you so much.
Yeah, and a deeper hole that keeps on filling with blood all the time. Yeah, because it's never, I mean, one of the most horrors of doing a DCR surgery is, the just blood keeps on oozing and, you have to suck it or clean it and mop it every time.
Yes.
Professor Elmer too.
It's been several decades since I've done DCR, but my recollection is with Dr. Chong was that the osteotomy was really the most challenging part. So if there's some addition you can put to your model that would help with that, I think that that's probably the most foreign and difficult portion of the procedure for most residents and fellows.
Yes, sir. For simulating the osteotomy part, I got one more idea that the pistachio shell, which we use, which is available in all kitchen. So that shell we can actually use for the osteotomy, and when we will do punching with this pistachio shell and the bone punch, it gives the exactly same feeling of the orbital bone, and it gives the same sound, and that brittleness is exactly same as the orbital bone. So that resident can practice if he wants to practice this step alone. So that is the other part.
Lovely, thank you.
Thank you so much.
Thank you. Would any other judge or panelist want to ask questions to Dr. Gupta? Well, then we can move on to our next presenter, and Dr. Somashila Murthy, learned scientific committee member, shall take over.
Thank you very much, Paritosh. Good evening once again. It's my pleasure now to introduce Dr. Soham Basak. This young man has over 15 publications in national and international journals. He has contributed over 2 book chapters already, and he has trained from and is a consultant in the cornea department at Disha Eye Hospital, West Bengal. The discussants for this particular innovation will be Professor Elmer Tu and Professor Chi Soon-Fik. Good evening, Professor Chi. Please go ahead, Soham.
Thank you so much for the introduction, Madam. I'll just start my presentation. Good day, everyone. I'll be talking about air-assisted donor lenticle insertion in DSEC in aphakia. I have no financial interest in this talk. So we know that doing DSEC in aphakia is always challenging. The air tamponade and lenticle addition is always difficult, and especially in presence of iris defects and with presence of vitreous in AC and prior vitrectomy. So the modifications by surgeons include putting an IOL in, having various suture fixation techniques, or putting various scaffold techniques to protect the DSEC lenticle falling. So my innovation is having an air-assisted technique where air is used to maintain the anterior chamber during the key steps. Sodium hyaluronate is never used intracamerally, and the donor insertion takes place while there is a pre-existing air bubble in the anterior chamber. I have a short video. So we have a one-eyed young patient with a small cornea with inferior iris coloboma and prior vitrectomy done. So there is some amount of BSK which has developed over time, and we can see emulsified silicone oil. I start by doing a little bit of a chelation to take care of the BSK, followed by making the side ports. then with bimanual irrigation aspiration, and also we prepare the sclerocorneal tunnel but not make an entry. The emulsified silicone oil is cleaned first, and then we proceed to place an air bubble in the anterior chamber. So now, sorry. So once the air bubble is placed in, the Descemet stripping takes place with that air bubble in place through the side ports. The advantage of not doing a main incision is it helps maintain the anterior chamber stability at this stage. Only once the Descemet has been stripped, the air main entry is made, followed by enlarging it. The stripped DM is removed. Now, after preparing the graft manually, this is inserted using the needle insertion technique. So just a bit of sodium hyaluronate over the wound, and the graft is placed. And using a 26 gauge needle, it's just pushed gently inside while the air is in the anterior chamber. So this is very important. The graft is placed so that it slides over the anterior chamber and underneath the host stroma, and very gently so that the existing air does not leak out. And that's it basically. Once that is done, we can secure all the wounds. There is no need of doing a further air fluid exchange. Just inject some more air to achieve ideal tamponade. So I had to suture the side ports. And we have some post-op photographs. This is at day 1 and subsequently at 6 months. And this is the serial anterior segment OCT photographs of the same eye. So over the last almost a year, I have done 7 such cases. And fortunately, there has been no incidence of graft dislocation or rebubbling. Unfortunately, the follow-up has not been great. So I have 6 month specular only of 2 patients, which shows about 25% to 30% cell loss. So in conclusion, an air-assisted donor insertion technique is a safe and repeatable technique for DSEC in aphakia with large iris defects. However, we need a longer follow-up to assess the long-term graft survival. Thank you so much.
Thank you, Soham. Professor Elmer, too. Your comments, please.
Thank you, Dr. Somashita. Good to see you, Soham. It seems like every few weeks we're seeing you, but it's a very elegant technique.
Thank you.
Can you give me details on your pressurization after the surgery? I mean, it's I assume a full airfill of the anterior chamber. Is it a high pressure, a low pressure? Do you have to suture the paracenteses occasionally? What are the key elements of the?
Yes, sir. So I try to get it to at least the 50s, in the 50s range. And as you saw in this situation, I had to suture the side ports. So in 4 of the 7 cases, I had to suture both the side ports to get an adequate air tamponade. And another thing that I ensure is I keep the patient in the recovery room for at least an hour without doing anything. And at the end of an hour, I check the patient again under the operating microscope. If required, I do a little bit of air, just remove some amount of air. But otherwise, as we know, if it kicks, the air does not tend to stay for long. So sometimes I just leave it in, because most of the time when I'm seeing them again in the slit lamp after 3 or 4 hours, usually the air has gone behind in their posterior chamber.
How about positioning for how long? And have you thought about using, or do you have the option of using gas rather than air?
So gas, yes, I do have the option. So in case of, if I feel that the anterior chamber stability is poor, I would like to use C3F8. But most of the time I would prefer air. And positioning, prone position, if I'm able to maintain that first 1 hour, I'm usually confident that the graft will stick.
Thank you. So good to see you.
Professor Chi?
I think I enjoyed your surgery. It was really very nice, elegant surgery. I'm just wondering what happens if you accidentally lose your air from the chamber as you are inserting, because you did it so smoothly, and I can imagine a beginning surgeon who looks at you and says,
Yes,
well, this is so
yes.
simple and so quick. So what happens if you lose the air bubble?
So the tunnel making is, I would say, the most important part of this surgery. We need to make a little larger tunnel than what we're expected to, and this will not work in a clear corneal incision. So for an 8mm graft, I would suggest a 5mm incision. And if I do lose the air bubble, I would go back to the usual technique, fill it with BSS and do the unfolding it in a BSS filled chamber as normally what we do.
Okay, and how do you adjust the centration of the graft? I mean, I don't do cornea surgeries, but I do very often watch my colleagues do it, and they would just use a Rycroft needle on the cornea surface and just, kind of sweep
so
it.
I use a reverse-Sinski and just sort of roll over the surface. For DSEC grafts, that's the usual technique on how to do it. Or if it is if it's not working out that way, we can just use it, same with the reverse-Sinski, from the inside, just hold it at one point and just drag it to center it.
Okay. And you mentioned that your endothelial cell loss is about 25 to 30%. My impression is that's rather high.
A little on the higher side, yes.
Yeah. Could you explain what could account for this loss?
So one is that the needle technique, along just because we are dragging it, that itself is a known technique of having a little higher endothelial cell loss. Plus, I would expect that these are more complex anterior chambers, so the post-op inflammation is also a little higher than expected. And maybe in some situations, there is some vitreous, which tends to, even post-operatively, there is some vitreous which tends to come forward. That might also explain some of the increased cell loss.
Thank you.
Thank you.
One quick observation. What if the air, in the post-operative period, say on post-op day 1, it goes into the vitreous because if the patient is aphakic, there's every chance that it can go into the vitreous on the post-op day 1.
So if there is no pupillary block and it has just gone into the vitreous and the iris there is not much shallowing, I would not do anything to it. Because by post-op day 1, I expect that the graft is well secure.
Okay.
Yes.
All right. So in the interest of time, I think we'll move on. Thank you, Soham. Excellent presentation. And thanks to Dr. Chi and Dr. Namrata and Elmer for your comments. I'd like to hand over to Sonu Goel to take up the next presentation.
The next presentation, I would like to welcome Dr. Swati Kalki, and she is the head Department of Ophthalmic, Plastic and Facial Aesthetic Surgery, Orbit and Ocular Oncology, and she's the head of the OEEU Institute for Eye Cancer, and she's a consultant ophthalmologist at the LVPI Hyderabad. And again, she's an adjunct associate professor at the University of Rochester, US. So welcome, Swati. You can start sharing your screen now, and she'll be talking on concomitant simple limbal epithelial transplantation following wide excisional biopsy of ocular surface squamous neoplasia. The lead judges, I would like to invite Dr. Kelvin and Dr. George. So all to you, Swati. You can start sharing your screen.
Yeah, thank you, Dr. Goel. A very good evening. So I'll be talking about the concomitant simple limbal epithelial transplantation following excisional biopsy of ocular surface squamous neoplasia. Okay, my slides are not moving.
Sunil, can you help?
Sorry about that.
Yeah, it's fine.
So I do not have any financial disclosures to make, and consent has been taken for use of photographs. Now, these are two patients with ocular surface squamous neoplasia who had failed medical treatment, and because of which excisional biopsy was done for both the cases. And as can be seen, both of them developed limbal stem cell deficiency. In order to reverse this, we went ahead and did secondary simple limbal epithelial transplantation, but post-operatively, as can be seen, there was recurrence of limbal stem cell deficiency in both the cases. Now, if we think back as to why this has occurred, it's mainly because there is surgery-induced limbal stem cell loss, and maybe also because there is already stem cell damage because of the tumor, which resulted in the limbal stem cell deficiency. So how do we solve this problem? This is by replacing the limbal stem cells. And we have seen that secondary SLET is not very helpful in such cases. So our primary research question was whether primary SLET, if we do in these cases, whether it is helpful. Whenever we excise an ocular surface malignancy, it is excised along with 4 millimeters of conjunctival margin and 2 millimeters on the corneal side. And we also lose the limbal stem cells if the dissection is at the limbus. We reconstruct the ocular surface by placing an amniotic membrane graft. And we thought of replacing the limbal stem cells by doing primary SLET in these patients. But the next question was, which patients actually require primary SLET? For this, we did a retrospective analysis, and we saw that when it is small tumors, then they do not develop limbal stem cell deficiency. But if the limbal stem cell loss is more than 6 clock hours, then these patients, they develop limbal stem cell deficiency. So we selected these patients to do a prospective study. This is the procedure that was done. The tumor was excised along with the conjunctival margins of 4 millimeters and the corneal epithelial margins of 2 millimeters. And the tumor was removed in toto. Double freeze thaw cryo was done. Amniotic membrane graft was placed. Limbal stem cells were harvested mostly from the contralateral eye. And then these limbal stem cells were cut into small bits and placed over the amniotic membrane graft. And these were secured in place by placing fibrin glue over it. And once this is done, a BCL or a bandage contact lens is placed to secure it in place. Now, this is a photograph which is taken after 1 week and can be seen that the SLET particles are in place. Now, let's see what happens to these by OCT. On day 1, we can see the SLET particles on the surface. By day 5, we can already see that the epithelium has to start growing from the explants that are present. And then by day 8, almost the epithelium has grown between 2 SLET particles. Now, this is 3 months, at 3 months where the SLET particles almost, they resolve. They're not seen anymore. And the cornea is clear without any signs of limbal stem cell deficiency. These are some of the examples where the tumor was excised and primary SLET was done. And as can be seen, the cornea has remained clear without any signs of limbal stem cell deficiency. We published our preliminary results of 7 patients where we saw that this procedure, it helped in preventing the limbal stem cell deficiency. And now we have done this procedure in more than 25 cases. To conclude, based on our results, we conclude that primary SLET after excision of ocular surface tumor involving more than 6 clock hours of limbus, it prevents or minimizes the signs of limbal stem cell deficiency. Thank you very much.
Thank you, Swati, for that wonderful presentation. So now we have the lead judges. So I would request Dr. Kelvin.
Thank you, Swati, for the wonderful presentation. I like the way how you document the growth of the epithelium using the OCT technologies. A quick question, any patients who are relatively contraindicated for these primary SLET in your series?
Yeah, so currently we do not do this on HIV positive cases because they already have very high chances of recurrence. So we do not want to do primary SLET in these cases. And second, if there is the limbal stem cell loss is extensive in that same eye and there are not normal limbal cells, or if there are suspicious limbal stem cells where we are not sure if it is healthy, then we do not do SLET in these patients.
So for these primary SLET patients, how many of them need a secondary SLET in case that primary SLET fail?
Yeah, at least till now in our 25 cases that we have done, we haven't done secondary SLET in any cases. Significant limbal stem cell deficiency features were not seen in any case, though peripheral panels just about 1 to 2 millimeters from the limbus has been seen in about 2 cases, but not more than that. So secondary SLET has not been done.
Do you think the use of primary SLET in your series also contribute to the relative low recurrence of the disease?
That may be slightly difficult to comment on. We initially, when we started doing this procedure, in fact, we had concern in the opposite direction that whether these limbal stem cells kind of can acquire the tumor and cause recurrence of the tumor. But so far, it has been comparable to when we do not do the SLET. So far we have done well.
Great, thank you very much.
Thank you.
Thank you. Dr. George.
Just a quick question. Are there any tumors or neoplasias in which you wouldn't do this? procedure?
Specifically, nothing like any tumors, but only I think based on the ocular surface, the quality of the ocular surface, that would be the main indication or the contraindication, but not specifically like a tumor that we have. We have been doing this in this series. Of course, I've presented on ocular surface squamous neoplasia, but we have also done on conjunctival melanomas and also one case of conjunctival lymphoma because it was extending till the limbus, but nothing specific that tumor that we have had a thought of a contraindication.
Thank you very much.
Thank you.
May I ask a question? Oh, you mentioned that most of these are from the other eye, but how many of these, if any, were allo-SLET? And do you think allo-SLET versus auto-SLET makes a difference?
We haven't done a comparative study actually to say whether allo or auto-SLET is preferable. The contralateral eye, it has been done in about 75% of the cases, mainly because there is significant stem cell loss in the eye where the tumor is removed. Because the criteria that we used was if we have to obtain the limbal stem cells from the same eye, then there has to be at least 4 clock hours of limbal stem cells that are remaining unhealthy. Which is the reason that we had to take it from the opposite eye in 75% of the cases. But yeah, we do not have a comparative study to say whether auto or allo-SLET is preferable.
So thank you, Swati. I would now request Dr. Amit Porwal to please continue. Amit.
Thank you, Dr. Sonu. So we are done with one Swati and we have one more Swati coming up as a young Turk. So she's also from LV Prasad. And Swati, can you stop sharing your screen till Dr. Partha shares your CV? Yeah, thank you. So Dr. Swati Kalki is head and Dr. Swati Singh, she's basically a clinical research ophthalmologist at the Center for Ocular Regeneration at LV Prasad Eye Institute, Hyderabad. And Swati, over to you and the lead judges for your presentations. We have 3 lead judges for you. The lead judges are Dr. Kelvin Chong, Professor Geoffrey Rose, and Dr. Yanchulev. So over to you, Dr. Swati.
Thank you, Dr. Amit. Good evening, everyone. Today, I'm going to show you a new technique of examining lacrimal gland and salivary glands. Traditionally, lacrimal gland has been examined using Schirmer's test or measurement of tear meniscus height, but there is a way where you can directly assess the activity of the gland. On slit lamp, you ask the patient to look inferomedially and you lift the upper eyelid supratemporally, and this exposes the palpebral lobe of the gland. Now, a normal palpebral lobe looks convex, has smooth surface with an overlying layer of conjunctival vessels. When we examined this lobe in dry eye patients, we found that the gland was reduced in the size, had flat contour, and there was an increased vascularity over the conjunctiva or over the lobe. Whereas in Stevens-Johnson syndrome patients with dry eye, when we examined, we found that there was a subconjunctival scarring, which was obstructing these ductules, resulting in dry eye. We recently published in BGO a comparative analysis of 25 healthy and 83 patients with dry eye disease and found that there was a significant difference in the size, shape, and the appearance of overlying vessels. Now, having seen the structure of the gland, there's a way you can assess the function of the gland. You touch a fluorescent strip onto the palpebral lobe, and this shows you the areas of fluorescent washout, which are secretory ductules. You can calculate the tear flow rate per gland using ImageJ software. You can count the number of ductules as well as assess the time lag. This is an example of Sjogren's syndrome where you see in panel A and C there is no secretion with the flattening of the contour, whereas in panel D there is only focal point of actively secreting ductules. Whereas in SJS there is a scarring and the arrow in panel B and D points towards the uninvolved area secreting the lacrimal secretions. So we compare these findings between normal controls, patients with evaporative dry eye and patients with aqueous deficiency dry eye. And we found that there was a significant reduction in the tear flow rate per gland, per ductule, between the evaporative dry eye and the aqueous deficiency dry eye, as well as the time lag. Now, interesting finding was that in aqueous deficiency dry eye, there was an increase in the time lag, that the secretion took time to appear after you remove the fluorescent strip, which indicates that there is a neural component involved in these patients, suggestive of a secretomotor dysfunction. Now, minor salivary glands are relevant to us for diagnosing Sjogren's syndrome patients or mucosal disorders or planning a gland transplant. In the inset, you can see that a smartphone adapter is mounted onto the iPhone, which emits the blue light. And the lower lip is smeared with the fluorescent strip. And you see these secretory openings of minor salivary glands. You can calculate the tear flow rate as well as measure them. Now, this was a lady we were suspecting Sjogren's syndrome in our clinic, and we did this test. And we found that there was a reduction in the number as well as the secretory flow through these openings. Another clinical use of this test is in planning a gland transplant. Like this patient, we deferred the MSGT surgery because there were only 3 focal points of secretions, which were not enough for collecting the salivary glands. Now, once the glands are transplanted into the eyes, how we assess the activity is by the surrogate measures. Let's say improvement in Shermer values or change in the fluorescence staining score. There existed no technique where you can directly assess the activity of this graft. For the first time, when the simple test of using a fluorescent strip, which has been moistened with normal saline, and when we applied it onto the graft surface, you can see these three secretory openings in the video, suggestive of the active minor salivary glands. Now, case 1 and case 2 graft look healthy with a good uptake. However, on fluorescent testing, there was no secretion coming through the case 2. So this test really tells you whether the gland is functionally active or the graft is just lying there with inactive secretions in it. So fluorescent assistance is a very simple, cost-effective, and a reproducible technique of examining lacrimal and minor salivary glands. And I thank my dry eye team and LVPI for their support. Thank you.
Thank you, Dr. Swati. So your lead judge, we go to Dr. Kerwin Chong. Dr. Kerwin, over to you. Your questions, please.
Thank you, Swati, for this very intuitive but beautifully designed talk and presentation. Any contraindication again on applying this technique to any of your dry eye cohort of patients?
Thank you, Dr. Chong. No, I don't see any contraindication where you cannot apply, except that suppose post-surgically in SGS patient, if there's a lot of inflammation and discharge in the ocular surface, and the patient has undergone any surgical intervention, let's say lid margin mucous membrane grafting or amniotic membrane grafting. So in those cases, because of the surgery, you will not perform that test at that specific visit.
I'm not quite sure if I can be as accurate as you and your team in assessing the flow of the tears. How would you help to objectify and compare that with the existing measures?
So with existing measures, practically which we have is the Shermer's test.
Right.
Yeah. So with the Shermer's test, the problem is that the repeatability value of Shermer's is to the tune of plus minus 4.5 millimeters. So let's say if a person has a 9 millimeters of Shermer values, in another person's head, it could be either 5 or it could be 14. So the repeatability and the coefficient of variance using this technique was very specific. It was not high. The repeatability coefficient of variation was 83%. Plus, this test measures directly the lacrimal gland. With the Shermer's, you have secretions of the meibomian glands, secretions from the ocular surface, then the lacrimal gland component. So there are the 3 components of the tear film which we are measuring with the Shermer's test, though it's mainly tells you about the aqueous component. But what you found was that the repeatability as well as the variation in the values was very less, and this test seemed more specific for the lacrimal gland assessment. We are on, we have already published, we submitted this paper is under review, where we have compared the values with the Shermer's test. So we found that in normal patients, there was no difference whether you do Shermer's test or do a lacrimal gland assessment using this specific fluorescent strip test. Whereas in patients with aqueous deficiency dry eye, there was a difference, a huge difference with the assessment of lacrimal gland activity versus Shermer test measurements.
I have some consideration because most of my, to my understanding, most of the resting tears are from the minus lacrimal glands, which you won't be able to test. But of course, these will be very handy, for example, in your last few slides or examples of salivary gland transplant. Those will be very, very helpful. So these were my comments. Thank you.
Yeah, thank you.
Thank you, Dr. Chong. Over to you, Professor Geoffroy.
Thank you very much, Swati. Does the number of glands relate at all to the patient's symptoms? the severity of them? In other words, if you treat them and they get a better secretion, do they actually get less symptoms?
Dr. Rose, you are asking this for lacrimal gland or the minor salivary glands?
Either, whenever you're treating ocular surface disease. In other words, does the number of secreting points, you know, around the eye, that is, not the mouth, does it relate to symptoms, interestingly, in the eye?
Yeah, so in our study, we compare the ocular surface disease index of these dry eye patients and the values related to the fluorescence staining score and the tear film breakup time. And the value of OSDI correlated well with the number of ducts as well as the decrease in the number of ductular opening. And we are doing, I cannot disclose the molecule name, but we are doing a periglandular injection of that molecule in fibrotic patients. And we have found that there is post-injection, there is an increase localized to that area of the number of ductular openings. So, and another study we are doing is for the Botox patients, where we're giving lacrimal gland botulinum toxin injections. So we are comparing pre and post injection, does the secretion per ductular opening or the number of ducts actually reduce in patients for, for our patients where we are giving Botox injections. And we are getting very interesting results, which do not correlate with the Schirmer values most of those cases.
Thank you very much. Well done.
Thank you, Dr. Rose. Now I would ask Dr. Yanchulev to put up his questions.
Yes, thank you, and I'll be very brief. I agree with everybody else. This is very simple and very elegant. Congratulations. How long does it take, is my only question, to actually quantify it? How much time does it take, and what is the learning curve to assess that? And can that be somehow incorporated into some sort of machine learning or directly into the diagnostic camera that one can use to make it much more standardized?
Yes, Dr. Sean, the test, so when we touch the fluorescence strip and you immediately take it off, then we are capturing a video. So at the end of 1 second, we take a frame shot from where we calculate the area of the openings. So the test per se is, if you make the patient sit and lift the upper eyelid and everything, it doesn't take more than a minute, hardly 20 seconds. And with the machine learning, now we are in talks with our IIT colleagues, where we are planning to build a image analysis software. The image is being fed onto that imaging software and can calculate the tear flow rate and everything, give it to you without doing a manual calculation using ImageJ softwares. So that it can also assess the rapidity of the secretions, how rapid the secretions are coming from one area and all those parameters. So that process of machine learning integration is underway.
Yeah, that will be very helpful.
Yeah,
thank you.
That will be very easy. Thank you.
Thank you, Dr. Yanchulev. So thank you, Swati, for your presentation. Now we have the last presentation of this grand finale, and that is by Dr. Veer Singh. And to moderate his talk, we have our scientific committee member, Dr. Feroz, taking over. Feroz, over to you.
Thank you, Dr. Ahmed. So we come to the last speaker, and thank you everyone for staying up so late. And I'm sure you're all enjoying the presentation so far. So Dr. Veer Singh is an excellent vitreoretinal surgeon at SB Dr. Sohan Singh Eye Hospital in Amritsar, Punjab. And I'm sure he's going to be the best. And all over to you, Dr. Veer Singh, and all the very best.
Thank you,
Give us a good show.
Thank you, ma'am. So I'd like to, good evening, everyone, respected judges. I'll just share my screen first. I feel like the odd one out. So good evening, everyone, respected judges. I'm going to be showing my mini PVD technique. Is my screen visible and am I audible, first of all? So am I audible?
Yes, you are audible. Yes. The screen is visible.
Yeah. So I'm going to be showing my mini PVD technique in flat membrane PDR cases. I don't have any financial interest, but I have a disclosure that one of the cases shown won a runner-up award at the IRSI 2020, where I also had the honor of having Dr. Boris Mack on the audience, virtual audience. In diabetic TRD vitrectomy, the difficulty level all depends upon whether there is a PVD or not. When there is a PVD, the membranes are lifted up. There is a dissection plane, plenty of space to work, and the case is easy. When there is no PVD, the membranes are flat. the plane is not there, there's no space to work, and the case becomes difficult. My mini PVD technique specifically is of great value in these flat membrane TRD cases. So normally one would search for a membrane edge, lift it up to get into the correct plane. Unfortunately, a lot of these cases have vitroschisis. You end up in the false plane. This is where my technique comes in handy. I never search for a membrane edge. Instead, I create one. I go straight to the disc, lift up the hyaloid just by 1 to 2 millimeters. This gives me a small PVD around the disc in the green zone. This is what I call a mini PVD. Now, this mini PVD creates space between the retina and the membrane. Opening this up gets me that membrane edge to work with, gets me in the correct plane on the second membrane, and even the toughest of cases become easy and they are managed very quickly. Coupling this with the 10K beveled cutter because of its angulated shape helps me work safer, closer to the retina and along the retinal contour. I'm going to show two videos. They are both flat membrane fibrotic PDRs. In the first case, you can see that advanced PDR. I never search for an edge. I go straight to the disc, lift up the hyaloid just by 1 to 2 millimeters. And you can see that arrow. The PVD is going to extend only up till there. That is how I control it. And even temporally, the PVD extends there. This is to get me that edge, that opening. Further on, I engage the cutter at the edge and everything else the cutter does. I don't do anything further. The cutter does everything else. It becomes so easy because I'm in the correct plane. You can see how the membranes just jump into the cutter's mouth. In fact, even that fibrotic bit, it comes off so easily without any bleeding because I'm in the correct plane. Nasally, these membranes are very adherent. So again, you have to do the same maneuver, create that mini PVD, just a disc diameter from the disc, and to get that edge. No need to search for a fresh edge, start from there. And you see how easily the membranes just jump back into the cutter. Again, working along that membrane edge, extending it into the periphery, and the membranes loosen up, they start coming to your cutter. Superiorly again, extending into the periphery, and that's the last bit of that membrane, which comes with a fold-back delamination. In fact, this patient did very well and got 6/12 vision at 8 weeks post-op. The case two again is a flat PDR. Here I use the cutter itself to induce that mini PVD. You notice a gush of blood that starts coming.
1 minute left.
That gives me an indication that the PVD has occurred. On the macula, you notice that's vitroschisis and the real hyaloid is under it. Temporally, nasally, I extend the PVD just short of those traction points and start the cutting action there. You get in between those membranes with the cutting action, no suction there. It's all due to the mini PVD that I created earlier. The membranes, again, on the nasal side, I freshen up that edge, lift that membrane up, create that edge, and from there, the job becomes easy, lifting it up into the periphery, and the membranes come right into the cutter. Superiorly, that same edge is being used with that mechanical dissection that we created with the mini PVD. This 10K cutter, beveled cutter, the shape is such that it just sits on the retina, and the membranes jump right into it without causing any iatrogenic break. That's how safe this cutter is. Here, further, you will notice there's a bleeder. Now, when this bleeder occurs, I use the same tip to give mechanical pressure on the retina and the bleeding stops. This is due to this excellent shape, angulated shape, which aligns flat along the retinal contour. Extending that same edge that we created earlier, no need to search for a fresh edge. And that's the last part of the membrane, which comes off, lifting up the hyaloid from the periphery, finishing up with an ILM peeling.
Time is.
And that's the last part of it. So these are some of the cases managed by this technique. And I would like to conclude that even the toughest of cases can be managed very fast and efficiently without the need to switch to bimanual surgery. Thank you. These are my references.
Dr. Veer, thank you very, very much. That was a very energetic presentation, although it was the last presentation. And now I request the lead judges, Dr. Rosha and Dr. Lingam Gopal, to initiate the discussion and your comments, please. Over to you, Dr. Rosha.
Congratulations, Dr. Veer. Very elegant techniques for vitrectomy. Do you think that you could do the same with 27 gauge? The same technique that you start lifting in the optic nerve and go further to the periphery is the same with 23, 25, or 27?
So I have done these cases. One was a 23 gauge and the other one was a 25 gauge. I don't have much experience with 27 gauge. So I won't be able to comment on that. But yes, I believe if we induce that mini PVD with the forceps, the rest of the job can be done with a 27 gauge cutter as well.
And you don't think you can do the same mini PVD just with the vacuum of the probe? You always need to use the forces to lift at the beginning. You don't think that you can do the same with only the vacuum?
So in my experience, the more fibrotic a membrane is, that takes the forceps. If it's not that fibrotic, that comes off with the cutter.
Okay, thank you.
Thank you, Dr. Rocha. May I request Dr. Lingam Gopal to take over now?
I think it's a good presentation, very good videos, Dr. Veer. I enjoyed your presentation. I just have a few comments to make that, yes, the removal of proliferative membranes in diabetic retinopathy can be made in different ways. Where you can start from the disc, you can start from the periphery. This is one very good technique which you have shown, creating space between the retina and the membranes over the disc and then proceeding forwards. But I still feel that there are situations where this may not work, like in an elevated retina. If the retina is elevated totally right up to the equator, and then you have this kind of a tissue stuck over the disc, it's easier to start from the periphery and go towards the disc. Likewise, a very atrophic retina is likely to tear sometimes even with the first step when you are trying to pull the fibrous tissue. So when the tear occurs in a uncontrolled way and you can't even see where the retina is getting torn. So there are situations where probably this technique may not be the ideal, but I still take it from you that it's a very useful technique to adopt in selected cases.
Thank you for your comments, sir. So, like I mentioned, this is useful in my hands in mainly these flat membrane ones. The ones that you said, the elevated retina, I feel that even periphery and the bimanual surgery works much better in those cases. So I agree with you on that, sir.
Thank you so much, Dr. Gopal, for those valuable comments, and Veer, excellent. So now I hand over this session to Dr. Partha Biswas. Dr. Partha?
Yeah. Thank you very much, Farouz. And we are coming to the end of the session. The session doesn't end before we obviously say that there are a few winners among the winners. So before we actually decide upon the winner, I would request all our judges to submit and upload their mark sheets. Some of them have already come in, as I just got the news from our IT backup team. Rest of you would request you to submit the mark sheets, please. And we have our judges and our scientific committee members while the mark sheets are being tabulated, which will take just about 5 to 10 minutes. Quick comments from our judges. What do you think of our talents that you have seen, the showcase of our talents from India? So, Professor Rocha, can you start off?
Was amazing to be here together and listen so brilliant ideas and discussions, and many of them I think gonna go forward and be helpful for the ophthalmology and prevent vision sight loss. I'm very honored to join you. Thank you very much to be here, and I congratulate all speakers that did a very good job. Thank you.
Thank you. Thank you very much. LG, sir.
I think it's been a very good learning experience for me, especially since I have been cut off from the rest of ophthalmology for almost, say, 25, 30 years. It's good to listen to beautiful talks and very educative talks from other specialties. I really enjoyed the presentation. I think I really appreciate what AIOS is doing to encourage youngsters to come forwards with new innovative ideas. And this is an excellent forum for sharing their ideas and thought processes. Thank you very much for making it possible.
Thank you very much. Professor Ji-Sun Fek, please.
I've enjoyed this session very much, and I really enjoyed the innovative ideas, creating tools that help ophthalmologists screen the public at large and not really having to spend that much to create these designer tools, and something that would really benefit your population greatly. I really congratulate the whole lot of 16 presenters tonight. Thank you.
Thank you very much, Professor Elmer too.
I want to echo the comments of the other judges. It's just been so much fun to be at a conference that's not just cornea, to see the innovation and the entrepreneurial spirit really that's alive and well in Indian ophthalmology. So thank you very much for inviting me. This was a pleasure.
Thank you. Professor Rose?
Yeah, thank you very much for the invitation. It's been great, and I've learned a lot about many specialities I've long forgotten. But it's great to see the innovation and the way your teams work together in a very technologically advanced country. Thank you very much.
Thank you very much. Boris, are you there?
Boris is not there.
Okay. Can we have a comment from any of our other judges?
Dr. Kelvin, are you there?
Yes, thank you, Feroz. I agree with all the judges, and necessity is again the origin of all the innovations, and keep this spirit on. I enjoy being part of these very innovative young generation. Thank you.
Thank you very much.
Dr. Kelvin. Dr. Beko?
Yeah.
I think all of my fellow judges have expressed a lot of the feelings that I have, but I think for me, the other important thing and how I gauge a meeting is whether or not I take something home. And certainly from this meeting, I picked up 3 or 4 different things that I'm going to try next week in the clinic and see if they work. So I congratulate the speakers on their presentations, and it certainly has impacted on my practice in that not only will I change some of the things that I do, but also change my referral practice. So thank you.
Thank you very much. And I would request our team members, the scientific committee members, to give quick comments while we are just getting the tabulations back.
Thanks a lot. This episode of the grand finale has been a great success with judges present throughout the world. We have judges who have got up very early in the morning. We have judges who have stayed up very late in the night also for this program. So judges all around the world who have evaluated our young talents, and our young talents have showcased their knowledge to these international judges. So thank you once again to our esteemed judges and our governing council, our president, AIOS, Dr. Mahipal, secretary, Dr. Namrata Sharma, and our dynamic, we call him our captain. So we all know who's our captain. So Dr. Partha Biswas, our captain, we just conceptualized this idea over a phone call. All of us were just chatting in a Zoom call, and we thought that let us take out the young talent and showcase the whole world what India has, and we have achieved. Thanks a lot to my team and my captain, Dr. Partha Biswas.
Actually, it has really been an achievement. Absolutely.
I'd like to echo the words of Amit, and it's been a wonderful journey. We'd like to thank all the judges for being with us. And I think AIOS is growing leaps and bounds under the able leadership of our president, Dr. Mahipal, secretary, Dr. Namrata, and above all, our captain, Dr. Partha Biswas. And our young dynamic team has been working day and night to search these young Turks. And Dr. Lalit Verma has been a guiding torch bearer for us. And I think it's been a wonderful show for these young Turks. And the future is, for these young guys. So all the best. And let's see who the winner is. And I think all the 16 presenters are the real winners for us.
Yeah, I would like to say some words that it's really been very fascinating, long, interesting, but enjoyable journey. And we all learned quite a lot from all these specialities. And the technical and fantastic brilliance of these young Turks, it has simply bowled all of us. And all in all, a very useful and innovative brainchild of dynamic chairman, Dr. Partha, and great motivation by our team, President Dr. Mahipal, Dr. Lalit. He has been a really motivating force, and Dr. Namrata. And thanks to all the esteemed judges, they really added value And it was truly and truly an international experience. And our young Turks have really learned a lot by making their presentation in front of these international judges. Sir. Wonderful, sir.
Yeah, and having actually the international judges has added a different sheen to the meeting, because all of them are from different parts of the country, and it could have always been said that I mean, there is absolutely no bias, and the young talent has shown that whatever they want to do is not just for Indian ophthalmology, but for global ophthalmology. And having so many international stalwarts give their opinions and their views on what is going on, I think this is something incredible that Dr. Biswas and the team has done with the AIOS leadership.
Yes, and as Parikshit has said, that an international flavor and lack of bias, this has truly lended that extra dimension to the finals. And everybody in the team has already echoed. I think this has been one of the most exciting programs and something that we're all proud of as members of the scientific committee. So thanks to Captain.
Thank you, Captain. And this has been a wonderful program. Thanks to all the judges who took out your precious time and even, giving your valuable comments and opinions and teaching on each and every cases that we had gone through today. And very proud of the youngsters who have given a fantastic presentation over here. Cheers to our team scientific committee, and thanks to the governing council who have always supported us for all the things that we have so far done. So cheers to everyone, and we are waiting for the results now. Over to Captain again, Dr. Partha.
Yeah, the results are just coming in. Just give me 2 more minutes, and
May I, Partha?
Yes, sir. Yes.
You see, as I said, it's a grand day for AIOS, specifically the scientific committee of AIOS, who has explored this possibility, and for last 6 weeks you have kept us busy. But believe me, this overshooting today by 1 hour is nothing compared to the knowledge, compared to the excellent discussions we had. You see, I could see discussions, although I was not participating because of the time constraint, but it was nothing overshooting. And you see, I do a lot of ILM peeling. ILM peeling means innovative, learning, and motivating. This is what I thought for this entire episode, what Partho you have done. So it has been innovative. It has been great learning because of the multiple specialties involved, and motivating. I'm sure a lot of people who heard it will motivate everybody to, do some more innovation and participate. And further, I'm sure that this will not be the last exercise by this scientific energetic team, and they will carry it forward also. So 3 cheers.
So many more surprises in the package.
Yes, I'm looking forward.
Yes.
Our participants, quick comments from a few of you before we start announcing.
Let's start from the last participant. Veer, do you want to say something?
Ma'am, absolutely a very thrilling and excitement platform, and having international judges from all over the world, I think it's a great opportunity for us young people. And thank you everybody for that.
Swati Singh.
Thank you, AIOS. Thank you to all the international judges for working in their odd timings. And it was a very, very great, interesting, and inspiring experience seeing our youngsters, my colleagues working on so many new things that I have to now gear up and work even more to raise the bar.
Swati Kalki.
Yeah, thank you very much to everyone who really worked hard to put this program together, and to the judges. And it's really amazing to see, so much is going on around us. Sometimes we may not be aware of it unless, fora like this come forward and we get to see what all is actually going around. So thank you very much for the opportunity.
Soham.
Thank you very much to Team Scientific Committee. It was a great opportunity and very inspiring. And the treat was basically presenting to the international judges as well. Thank you.
Dr. Rohit Modi, is he there?
Yeah, it was a fantastic opportunity for young ophthalmologists like us to present our work, and it was a great learning opportunity as well. Thank you, AIOS.
Dr. Parth Rana.
Yes. So we have the results all in place. And before I announce the results, thanks to everyone. Thanks to our wonderful, wonderful judges, not only of this session, but of all the 5 sessions that we have held. They have contributed so much to ophthalmology. They have inspired, and all the participants of the 5 previous zonal talent search programs that we have had. Thanks, everyone. Thanks to our chairpersons, our governing council members who have been so gracious, and Dr. Maipal, Dr. Namrata, Lalit Verma sir, all have sat throughout these programs, 5 programs, and this is the 6th one. And of course, to our wonderful participants who have made life so, so wonderful, so vibrant. Thanks to all of you. And of course, to the people who have worked backstage. The first, I have to say, Intas Pharmaceuticals, who have sponsored all the programs, all the 6 programs, and thanks a mile to them. Our team at Scientific Committee, the vibrant team that you see, the smiling faces, working day and night for these programs and so many others. And our back office team, Pallavi Datta, who is our main strength, Mr. Kripal, Mr. Sunil, and the rest of the others who have contributed, Mr. Sunny, who has also contributed so much for this program. So now I wish to declare maybe from the 5th place. Let me declare from the 5th place. And the 5th place goes to CM T-Flex IOL, an innovative alternative for spherophakia. Dr. M. Nivian. So big hands to Nivian. Thank you for such a wonderful presentation. Congratulations.
Thank you, sir.
I would request Dr. Namrata Sharma to announce the 4th place.
So the 4th place goes to someone who we have already awarded 2 weeks ago for the innovation. And we've already given him an iPhone. So I think the person knows already. It is Dr. John Davis Sakura for smartphone portable eye clinic systems. That is the specs.
He was already smiling before.
The iPhone was
I could
a
see that. Congratulations.
Thank you so much.
Very good.
Congratulations.
Dr. Natarajan, I believe, is not here. So I will take maybe the pleasure of announcing the 3rd place, and the 3rd place goes to concomitant simple limbal epithelial transplantation following wide excisional biopsy of ocular surface squamous neoplasia. Dr. Swati Kalki. Congratulations, Swati. Congratulations.
Congratulations, Swati.
Thank you. Thank
So
you.
a quick word from you, Swati. How do you feel?
Yeah, of course, I feel very, very happy. And it really was a great opportunity. And as I said, I think for me, the more happiness was like seeing so much talent around, and it feels really good. Thank you so much.
Yeah, everybody is wondering now who are the,
Shall we keep
say that? I'm wondering
a little longer? John,
Maipal knows everything. Maipal knows everything.
who are the other 2? Are you not wondering?
John, you have something to say?
Some guesses.
It was a very innovative talks. I was listening to each one and getting ideas for new projects. So I think I learned from each and everything. In fact, it was from all specialties: oculoplasty, retina, cornea, and all over. So I think I got a few ideas to work on, and I think it is unpredictable who would be the top.
Phenomenal. Thank you, John. And now Lalit Verma sir is going to announce the person in the second.
The second, you see, I was just wondering, once you were announcing the 3rd, so how can the other Swati lag behind? So these 2 Swatis, you see, have made AIOS proud. I have heard them so much, although I don't do any plastic or lacrimal surgery. But congratulations, Swati Singh, for this. I will read out that topic: a simple and novel application of fluorescein ophthalmic strip in lacrimal gland and salivary gland evaluation. Congratulations.
Congratulations, Swati.
Thank you, Dr. Lalit. Thank you so much. Thank you. Very important contribution.
So congratulations to both the Swatis.
And now, Maipal sir, before you announce the person in the 1st place, some words of wisdom from you before.
Okay. Well, the only thing that I was going to say, which partly Dr. Lalit said, I think greatness is contagious, they say. So I think innovation should become contagious. There are so many innovations that people have shown that I think we have a very bad contagion going on just now. That's the COVID. But I think this contagion, which is something which is going to bring out and blossom the youngsters, this contagion should become infectious. And I think all the youngsters should come forward and learn from the others and take the हौसला. वो कहते हैं पंखों से क्या होता है, उड़ान तो हौसलों से होती है. So I think they should get the hostler to kind of come forward and bring out the innovation that India India has, but is not able to bring out to fruition. I think there will be a marginal difference between people who have actually perfected a technique to a larger extent versus those who gave an idea. Because that is the thing that ultimately needs to be executed to perfection, that you have an idea, you have to make it available, viable in everybody's hand. And that is something that is going to help improve science. So I think one of the speakers or one of the judges said that there is a lack of coordination between a person having an idea and somebody hand-holding him, doing some bootstrapping to kind of take this idea to fruition. But guys, I think the age is coming for India to take these things forward. And I think we should all put our energies together to get these innovations at the world stage and to give the youngsters of India their due in the world platform. So I think with that, I will wish to say, थाम के बैठो अब बारी है कि कौन जीता. So I think any guesses by anybody?
Nobody is going to risk taking.
Everybody is a winner from scientific committee. Everybody is a winner, sir. So we won't take any particular names.
Nobody will risk taking a name now.
I think if somebody got a fantastic picture on the cover of an international magazine, he can't not be the first. And the prize goes to Dr. Nilesh Kumar for smartphone-based gonio imaging. Congratulations, Nilesh, for your excellent work. And that's what I was saying, that it's something that anybody can do, and it really fired our imagination that this is something which is going to make gonioscopy simple and easy. Congratulations.
Where are you, Nilesh? A few words, Nilesh.
Thank you so much. Nilesh, to say a few words, I have to tell you that you are rich by 50,000 rupees. And
thank you.
So
I am richer. I am more richer by more experience.
And Swati Singh is rich by 30,000 rupees. And Swati Kalki is rich by 20,000 rupees. And John, you're rich by 10,000 rupees. And Nivian, you're also rich by 10,000 rupees. So congratulations. It's not the richness that matters, but it has been the richness of your presentation, of your ideas, of your participation. Thanks a ton. Yes, Nilesh.
Thank you so much, sir. First, I would like to thank my state society for providing me this opportunity. Dr. Partha, sir, AIOS, and my mentor, Dr. Ashish Sharma, for really helping me in this journey and to achieve the dream. And sir, one more, sir. Today is my anniversary. I would like to thank my wife to allow me to do this. Thank you so much.
Fantastic, Nilesh. So your wife should deserve the biggest thanks, you know.
I think wife is standing
going for shopping, sir. This is going for shopping.
Shopping will make you 1 lakh. 50,000 se wife thodi manti hai.
Amit, I can see his wife standing beside him.
Left side में wife है.
Nilesh,
we can see.
Congratulations. You can get your wife on the screen and tell her to. I mean, we can thank her for allowing you to be a part of this presentation.
She just stepped out, sir. The phone just rang. She just stepped out.
Okay.
I think it was a great program, Partho. Congratulations to the entire team. And I think ultimately AIOS is the winner, I think.
Yes.
No?
Yes, absolutely.
So because you have helped to search for all this talent. And congratulations to the entire vibrant, energetic team of Scientific Committee.
The richness of knowledge has spread globally, sir.
Yeah.
We are rich by the knowledge.
We'll not talk about further adjectives. क्यों चलते रहेंगे
Thank you very much.
So, bye, good night.
Last thanks to our international judges, Dr. Boris Mulligan, Professor Chisun Fek, Professor Elmer Tu, Professor Geoffrey Rose, Professor George Biko, Dr. Gopal Lingam, Professor George Rosha, Professor Kelvin Chong, and Professor Sean Anshulev. Thank you very much, sirs. Thank you. Thank you so much.
Thank you.
Thank you. Thank you so much. Thank you, everyone.
Bye-bye.
Thank you.